That usually comes up on my, yeah, it's there, yeah. Okay. So we're recording our proceedings. Good morning, everybody, and welcome to our Bradford Teaching Hospitals board meeting in public. And of course, as ever, things are slightly difficult, of course, in terms of inviting people to join us and certainly being face-to-face just at the moment. But we record this board meeting and we publish in full the recording of the board meeting. And it's our attempt, of course, to be as transparent as we can with the public of Bradford and beyond as to how we make our decisions, and quite rightly so. Colleagues will know, of course, that we publish the agenda and we invite any questions or comments. I'm not aware of any on this occasion, but that's the way in which we try to achieve the transparency that we all want to see. So good morning and welcome, everybody. I note apologies from Barry, and I do know that some colleagues just have a couple of conflicting arrangements. Janet is just going to join us a little late due to a conflicting arrangement. And Mohammed, I know, has to leave somewhere around 1 o'clock for some business in London that requires travel, I believe. And John, thank you for reminding me that you are going to join a neonatal meeting today at 1:30. Thank you. And similarly, Karen, thank you for your courtesy to me, advising me of a mental health meeting that you are going to go to around about 1:35, I think. Maybe for 20 or 25 minutes. And I suspect as chief nurse, you'll be opening that, Karen. So again, thank you to you for informing me of that. So that's entirely appropriate, of course. Indeed, a good forum for you to be at. So have I captured all the apologies, or has anybody had any late commitments that they've perhaps not just been able to tell us beforehand? It would appear not, in which case, other than Barry's absence today, and good for him, a little bit of time off, I think. That's terrific. Again, we've got a full turnout for our board meeting, and I'm grateful to you all for that. Okay. Big agenda, of course, some quite significant transactional matters. And I will, of course, welcome our pharmacy colleagues in a moment, but let's just set ourselves out as to what we're going to do today. It's kind of the normal format, of course, of dealing with our academy business in a way of focusing what we need to think about. But before that, we'll talk about the Trust's clinical strategy and look at the new format of our board assurance framework and the way in which we might address risks that are brought to our attention. We will consider our mental health strategy, and indeed we're being asked today to approve our procurement strategy. And Altaf, just a heads up, I think you have had at least some involvement in that, and I'll certainly, when we come to that item at item 10, welcome any thoughts that you might have in your role, of course, as some form of independent scrutineer of what we're doing there. Great stuff. We'll take finance and performance first today. So thanks to Julie, and of course, I think we'd put that kind of later in the agenda in previous board meetings recently. So we'll take the two chairs meetings from the last two meetings in March and April. And of course, anything Julie wants to bring to our attention from more recent times. Under quality, we'll take the chair's reports, of course, and we will have our usual standing item of maternity services update. Colleagues will have noticed that there's a significant focus on neonatal services there, and we'll be pleased to welcome Sarah, of course, to join us for that. Karen, as always, will bring our attention to anything related to the vaccination programme, and we have Professor Rebecca Lawton joining us for a brief update on research activity in the Trust. And a reminder to us, of course, another standing item there, compliments to us as colleagues in terms of how we treat research as important for great service delivery in our hospital. We'll then move to people, and of course I'll invite Karen to lead that with the academy reports and anything she'd wish to bring to our attention. We have again the standing item of how we are looking after our people in keeping with the National Health Service #1 priority of our workforce. And we need to give some time, don't we, to the staff survey results and hear from Pat. Of course, we've seen the papers, I know, but we need to hear from Pat as to what the key messages were there and what our intentions are in relation to dealing with those. Mel will bring our attention to anything from the Equality and Diversity Council. Thank you, Mel. Again, we've seen the papers for that. And then we're being asked to approve the Strategic Nurse Staffing Review. And again, I know there's a significant number of papers there, but we'll turn to our friend Karen, and I'm sure Karen will bring to our attention the key points that we need to be focused on. So thanks for that. Having taken the Partnership Board dashboard, we'll then deal with audit and assurance matters, and of course there's issues from the audit committee there. Julie, I think we may just turn to you, please, there. Would that be okay as deputy chair of that audit committee in Barry's absence? Or would you prefer me to...
Barry's already asked me, so that's good.
Oh, perfect. You're teed up for that. That's great, Julie. Thank you. And we'll be asked to approve the new terms of reference, which I think, if any amendments, are very minor. Under governance, I appreciate I'm taking a little time here, but I do want to just set us up correctly for the full meeting. Under governance, we will take a number of items for approval. I won't read all those out, but you can see them at section 5. A significant amount of reading. Again, I hope colleagues have had the chance to go through those 5 to approve. But again, as ever, we will turn to John and to Paul and hope that he will bring to our attention as his executive assessment of what the key points are we'd want to consider. We've got the fire safety report and the security report. And just a heads up to colleagues that item 31 on the security report, I think that from Mark will just be a brief briefing with a view to bringing back a full report to us a little later. I think some of the pandemic responses just meant we've knocked that back a little bit in terms of time. My understanding is it doesn't mean that we've diminished any of our responsibilities there, but just that the reporting has just dropped back a little. So Mark will obviously bring our attention to that. So that's what we hope to get through. As ever, I'd like to ask at the beginning whether there is any other business that anybody would wish me to make time for. So can I check, please? There's a significant amount, of course, of work on there, but that doesn't stop any director or indeed anybody else bringing to our attention anything they'd want to. I'm going to take that as there is no other business at the moment. Okay, that's fine. And hopefully we can get into things and have plenty of debate. And then obviously, I will say in open board that we do turn to a closed meeting at the end of our open board. And that's matters which quite properly might not be in the public domain. And at the moment, we simply have an opportunity for our CEO to bring to our attention anything that ought to be held in closed meeting. And we have a report on the way in which we're managing disciplinary processes. And that's an annual report regarding the way in which we are managing those for our staff. So we'll deal with that at the end of our open board meeting. I'm pleased to say there's very little in that closed meeting, quite properly so. Okay. So that's what we're going to try and get through today. But of course, the big thing and what we always, as a group of directors, enjoy is the insight that we get into certain aspects of our hospital work. And today, that's going to relate to the modernisation of our pharmacy services. Now, I can see Scott and Danny on the screen there. So a warm welcome to you both, guys. It's great to have you both with us. Thank you for giving us some of your time today. And do we have David as well? Is David with us?
We do, Max. David is on the call as well.
Is David on the call as well? That's great. I'm just looking through the name. Oh, I can see you, yes. Yeah, I can see David's name on there. That's great. Okay, so in keeping with how we would normally do this, we'd normally turn to the exec director who might be responsible for this particular area so that he or she, of course, can just orientate us, bring to our attention what this is about, what we might want to think about. And then it's over to the 3 guys to hear about the modernisation of pharmacy services. And again, thank you to you guys for the slides that have been presented. Directors will have had the chance to look at those. So it's a great opportunity for you to focus in on what you think we as a board should be aware of and matters you would like either our support or to bring to our attention. So Saj, may I turn to you, please? And we'll begin with item 3. At modernisation of pharmacy services. Perhaps, Saj, just before I do that, of course, I should check, having gone through what the agenda is of any other business, are there any additional declarations of interest to be made, please? We do have the record of declarations. Just let Janet in. Good morning, Janice, if you can hear me okay. So I'm assuming that having reviewed the agenda, there's no other interest that anybody wishes to bring to our attention, and I'm sure you will as we get into discussions. Thank you. Apologies for interrupting you there, Sarge. I'll pass to you now.
That's okay. Thank you very much, Max. And it is actually my pleasure to introduce to you Scott and Danny, who I'm sure will introduce themselves again, who are our pharmacy assistant and senior pharmacy assistant. They'll be talking us through the work that they're doing around pharmacy procurement and distribution, but in particular the stock top-ups. They've already shared the slides as you've highlighted, and you can see some of the excellent work that's been going on there. We've got David on the call as well, and David, of course, is our Director of Pharmacy, and he will be able to obviously pick up any specifics that may arise as a result of the discussion there. So if it's okay, without further ado, I'm going to hand over to Scott and Danny. They'll start with an introduction, and then Laura or Katie, if we can display the slide set, that would be excellent. So thank you. Thanks, Scott and Danny.
Hi, I'm Daniel. I'm Senior Pharmacy Assistant.
And I'm Scott. I'm just Pharmacy Assistant, so I'm just below Danny.
And you are both coming through nice and clearly, guys. Yeah.
Good.
Good to hear. Yeah, so in stores at the minute, we've got several projects which are on the go. We've started one that me and Danny are spearheading is the stock top-ups improvement project. There will be another 4 of them as well, which I think have sort of started, but they're not quite as far ahead as we are on those at the minute.
Which is on the next slide. If we can just see that next slide, we've highlighted the one that we're doing.
There we go. So the green section that's circled is the area that me and Danny are spearheading, and some of the other team members will be working on some of the other things, and I'm sure that they'll all eventually sort of mesh together in some way. We'll be able to sort of help out across the board with all the projects. So just starting off, can we just go to the next slide, please? Thank you. So I won't sort of rattle off. You can all read, I'm sure. I won't rattle off everything that's written down because it's quite tedious having to listen to someone whilst it's sat there in front of you when you're reading it as well. So these are the principles that we have in terms of the project and what we want to be delivering to the trust across the board. So we want to make sure that all the wards are obviously stocked up correctly by the right team members that we've got, and that they're trained well enough. We want to have regular reviews of all those stock lists to make sure that the department's correctly stocked with the right drugs and medications. Sort of tying in with the first one, we want to make sure that everything's picked correctly from stores and delivered in a timely manner to the ward as well. We're going to be working on we have an emergency cupboard up on one of the levels in the hospital, which is used when pharmacy stores is shut by staff. So we're going to be working on that as well to make sure that everything that's stored in there is correct and stored in a safely manner as well. We've got numerous IT issues in pharmacy stores at the minute, which is hindering us quite a lot in how we perform in our job roles. Which we would like to work on moving forwards, but I'm sure we'll get onto that going into detail about that. Is there anything you want to add in? No?
No. Can we go to the next slide, please?
So in terms of the principles that we've got for the project, these are 3 of the main sort of ones that we want to be combating, which is obviously we want to be making sure that we're delivering our medications in a faster and more timely manner to the wards so that the patient's not without, because at the end of the day, all this is it's all about the patient. It's not trying to make our job. I mean, obviously we would like to make our jobs easier, as anyone would, but the patient is the key aspect in all of this. We want to improve the morale of clinical staff throughout the trust, because as it says, the COVID situation has not helped anything. I'm quite sure nurses and clinical staff were quite stressed out before COVID hit, and COVID has obviously had a massive impact. So if we can do anything to alleviate a lot of the stresses that are occurring on the wards, then that's a bonus to us. And in terms of working together as one team in the trust, it's all going to be beneficial for us, that the nurses are happier in their job roles. And then finally, the last aspect is ultimately we want to save money for the trust and make sure that the money that's saved in one area of the trust is used correctly in another area, and it's used in the right way. Got anything to add?
No, that makes it all that one's got enough.
Okay. Oh, you've done it. Thank you. Sorry. So we want to make sure that the medicines that we are delivering are available to patients in and outside of usual pharmacy hours, that the right staff are obviously trained to be able to provide those medications to the wards, so that we're working on training staff within pharmacy stores, but also we want to train all the clinical staff, all the nurses, the nursing team that deal with any medications on the ward. So, for example, I've got a meeting with Ward 2's nurses this morning at 11:30, so I'm going to go up and show them how it is that they order medications from us as an ad hoc request, because we are finding that there's a lot of issues with and sort of differences between day staff and night staff and how they're ordering, and a lot of them are doing it incorrectly. It's not across the board, it's not one set of rules which should be applied. It's coming up with a lot of issues.
Efficient processes. So the efficient processes, when we're doing this, me and Scott, we're teaching the nurse on the ward how to do this. The part of the project is we're going to sort the cupboards out, clean them all up, tidy them, put them in alphabetical order, take the expired stock out of the cupboards, excessive stock. So the nurses then can put more time into patient care. So when they're filling the drug trolleys up, there's going to be no errors or near misses by picking the wrong drug up because they've got too much excessive stock in one cupboard. So when the nurses can go into the clinic room and do that, they can just go into the cupboard, pick the drugs. It's going to be so faster for the patients to be seen and the patient care for the nurses to have more patient care and more time with the patient. So that's quite a big one, that one they're doing that one. It's just so no mistakes and errors. And like I say, we've already done Ward 28, and I'd love anybody to go see it if you want to. That we've had a really good relationship with them. The cupboards are amazing. We've sorted them out, got rid of all the expired stock. They're doing great stock rotation. We've added the drug called rivaroxaban onto the list, which is beneficial for the staff, which also, with things like that, it benefits the pharmacy stores and dispensary, because then you're not getting requests, so then you don't have to dispense it for the patient, the ward can do it. So things like that, it's like benefiting them, getting that good communication and bond with the nurses to help us as well, because me and Scott, like I say, we're not nurses, we don't know what the drugs are for. It's a bit of education for me and Scott, and it's a bit of education for the staff on the wards as well. So it's great bonding and great communication, which makes morale a lot better for the trust. And it makes you want to do more and be more determined and more enthusiastic to get out there and do more.
Yeah. I think when we first started the project, we had clear principles what we wanted to do to benefit the ward and pharmacy stores. But as time's moved on and we've built more of a rapport with some of the clinicians and different staff members across the trust, we've come to find that as everyone's aware, the morale's quite low, and so that in turn from us doing what we've done in the beginning of the project, we've actually got another principle to work on, which is to work at making the clinical staff happier in the jobs that they do, make them want to come to work rather than have to come to work and be struggling. But just going back to what Danny said about the tidying up the clinic rooms and removing medications and everything, there was another aspect that we've sort of overlooked a little bit as well, and it's a big issue, but related to what might seem a minor problem, which is a tidy clinic room. And a tidy clinic room, if you have a tidy clinic room, it might actually result in a patient not dying. We've found that if you have a messy clinic room and your medications are all over the place, you've got too much, you're having to hunt around for medications, that might be 30 seconds, you know, of a patient who's having a hypo or needing CPR, or, you know, the clinical staff are spending more time in the clinical room when they should be in and out, grabbing what they need and leaving and going back to the patient, rather than having to dig around and start, you know, playing the digging game, trying to find anything that they need. So in terms of, you know, tidying it up, when we've mentioned to staff, it might seem a little silly thing that just to have a tidy shelf. But I'm sorry, our phone's going off. I do apologise.
Okay.
Will you just take over, Dennis?
Sorry.
Sorry about that. Apologies. Thought it was
No, well done. Quite right to take it.
That's totally thrown me now.
No, it's quite right. Yeah.
Are you okay to move on to the next slide, please?
Yeah, no, that's great. You made a great point there about tidiness and efficiency in terms of the service to patients. So well done. No, it's absolutely fine. So we move to progress, yeah?
Yes, please, yeah. I'm just reading my notes as well, so apologies.
Okay.
So yeah, we've introduced using laptops. Previously, about 4 to 5 months ago, we were having to go to the ward with a paper stock list, mark down what it is that we need, and then come back to pharmacy stores, issue all those meds, and then go back with those medications and deliver them. So now we're actually using laptops on the ward. So when we're on the ward, we're issuing the medications straight through the system down into pharmacy stores, where the paperwork's printed off, and the staff who are in stores whilst we're on the ward are already picking it. So it's knocked off a lot of the time in terms of how fast we get medications to the ward. We have done an audit, which we'll get to further on in the slides, in which were the worst wards in terms of ordering and things like that. And we've noticed that it's halved about the timing, just by introducing the laptops alone. So that's been really beneficial. We've been working with one of the members of the quality improvement team, Lisa Jameson, if anyone knows her. She's been really helpful in, you know, helping us collate our data together, getting sort of bar charts and graphs and everything, and showing us the sort of training us more in a sort of a quality improvement manner, rather than just thinking about our job roles. It's about how we can learn to make changes and positive changes in a more A to Z manner, rather than winging it and trying to, you know, come up with solutions when we don't know if it's even going to work. So we're sort of collating our data, acting upon that data, and then coming up with a more substantial solution to the problem that we've got. Got anything to add? No. So we've got also, when we are altering our stock lists, we're asking a lot of the nursing staff to, the ward sisters and the ward manager particularly, to go through their stock list and remove anything that they're not needing at this moment in time, or to reduce any of the quantities that they've got of medications. So that alone in itself, it provides a saving for the trust. Again, we'll get to some of them figures in one of the next couple of slides. So we've got some examples of the money that we've saved, but that's been a really positive thing for this project. So in terms of, you know, the NHS's budget and everything, that's really the work that we're doing here is saving a good amount of money so far. And we're only at the beginning of stages of this project. We want to hold some different group meetings with the staff members, just so they can provide us with some of the knowledge and experience that they've got. Me and Danny have just recently started going to the pharmacist meeting, which is just above pharmacy stores. So we meet up with the pharmacists on a Monday, Wednesday and Friday morning, just for a quick sort of get together and huddle, just to see if there's any changes that have happened. And I've also created a ward progression document, which I'm happy to send to Mel or Karen or anyone who wants it. Where we just, every time me and Danny go to a ward, we're just documenting the experience that we've had and the things that have been said with particular staff members, and then coming up with a sort of little action plan as to what we can do in terms of following up with that ward with the problems that they've got occurring at the minute. Anything to add? No.
For me, mate.
The changes we made have had different effects on different departments. So we've got the pharmacy stores, we've got pharmacy dispensary, and we've got the dispensing support unit, which is down the corridor as well. And then obviously the pharmacist team, which we just mentioned. So all the changes that we're making in this project are having, good positive impact on those staff members and the way that the different teams are working. And finally, as I said, we'd come across another principle that we wanted to work on, which was the staff morale and the mental health of those staff as well on wards, and our team as well. Well, any staff in the trust particularly, but which is reintroducing the principle that we are one team. There is a bit of, I don't know if disparate is the right word, or that there are sort of, I'm in this team, you're in this team, you do your job role, and it doesn't matter, we don't mesh together, when in fact we do. It's become quite evident, hasn't it?
Yeah.
So we want to be working as one team in a more streamlined and uniform manner together and act as one. Can you go on to the next? Oh, you've done it, thank you. Read my mind. So this graph here, this isn't what happened in terms of the introduction of the laptops in our top-up process. So previously, we've got the median, which is the red line across the graph, and we've got the time that it's taken to top up in minutes. So if you look across the bottom, we've got all the different wards. It goes mods, mod theatres 1 and 2, and then it does eventually go back to mods theatres 1 and 2, and that is where the change happened, where we've introduced the laptops. So the timing that it's taken to do that is actually halved thereabouts. So that is in itself a really big positive for us. We're getting those medications to the patients on time in a more quick and effective manner.
What faster? It's just like Scott was saying, you can see the line where you can see it's taking like roughly 15 to 25 minutes off a top up. Now, if without a laptop, we had to do it by hand. So basically, it was like scan it onto a computer, then print it off. So the process was a lot longer. So with this process, like Scott was saying, it's faster, it's effective. The patients get the meds on time. The meds are on the ward. For example, if a patient is coming out of theatre and they need a certain thing, at least pharmacists then provide a better service to get the drugs to the ward when the patient gets there. You don't want the patient there and the patient have to wait. So that's one of his main things, is the patient. We've got to think about the patients in this. So this slide just shows the progress that it's going at, how fast it's the project is, and with technology that it's a lot faster getting the drugs to the ward, so the patients are not having to wait for when they come back from, like, say, for example, having an operation and they need paracetamol, it's there for them. At least the nursing staff on the wards then look at it and go, oh, they're great, these guys, blah, blah, blah. It's there waiting for us already, It's better for the nurse as well, they're not having to wait and they're not struggling. They can just straight away administrate it to the patient. So that's a really good thing about the technology.
Yeah. Are we all right to jump on the next slide, please? Thank you. So these are just a few of the examples of savings that we've made from removing overstocked medications or having a change of their quantity level to medications. So they may have kept 10 boxes of paracetamol, for example, and they've dropped it right down to 2 because they've seen that the usage isn't that great. So that in itself is a saving, along with the removal of medications from the stock list that they're not using anymore, and just the amendment of the stock list. Sorry. So yeah, cardiac cath lab, we've saved £2,100 odd, X-ray £650, 14, £2,300 odd, and ward 19 was about £860. So when we are removing and amend medications from a ward, or we're amending a stock list, we're building up a really good rapport with some of the ward managers and sisters. We're getting some good feedback on them on how they want their staff to change and the training that they're going to put in place for their staff as well. But we've had really good, good positive feedback from them, and showing them these figures and visibly showing them in, you know, in a box what it is that you've removed from their clinic room. It's having quite a good impact on them to want to change and want to change the way they're working. And they've all been, well, we've had some issues with some staff. Not everybody's great with change. So we've had the odd occasion where we've had disagreements about how things should be done. But all in all, a lot of the wards that I've been to have been quite on board with what we're doing, and they understand the relation that it's going to have for you know, making their ward a better place for patient care. So in terms of those 4 savings alone, we've saved about £6,000, and this is in the beginning stages of this project. You know, there are a lot more things that we could be doing and to probably save more cost as well. But just, you know, this is probably, I put the last few months, it's probably in the last 3 to 4 months that these changes have happened, and since then we've done more as well. But obviously I had to send the slides in, and we couldn't amend the slides that we'd Saj had me on a deadline. So
just one on this as well. Before we did the project, Mark, you might know James Taylor and Andy Yates, and Saj, you might know, a lot of other people on the board might know these 2 gentlemen. In 2019, I did one with Nucleus Theatres with James Taylor and Andy Yates, and I saved them between £15,000 and £25,000. And the stock list hasn't changed since then. So for 3 years, the stock list hasn't changed. So that's another reason why you can tell these changes are good, because the stock lists are not changing. I mean, I've got it in black and white in my tray down where I've written down all the stuff, and it was a lengthy process, believe you me, but the positives that came out of it and how good I felt in myself doing that little project with the 2 lads, it was just phenomenal. And it's all, if anybody ever wants a copy of it, I can get a copy to you, so I can show you how I did the whole process and how good it was. But it wasn't part of the project at the time, but I wish it was, because it's just phenomenal. There's no problems with it all. I've had no problems. It's like 3 years. I mean, if you look at the money, I mean, it's a lot of money. A penny saved here and a penny saved there is a penny spent somewhere else better in patient care. That's the way I see it. So, and I'm a money saver, definitely, in these kind of projects. I love doing that.
Yeah,
it's my forte, if I may say so.
I think one of the most beneficial things, I know that this is not something that we've done as part of this project, but that just shows the, you know, the scope that this has got for the changes that we want to make. And the changes that Danny made back, you know, several years ago, they're still implemented and it's still the same. So it's not just saved over that 1 year, that those changes have remained like that, and that cost has been saved every year. So anything else to add?
No, I'm happy with that one.
No?
Nope.
Could we go on to the next slide, please? Thank you. Yeah, so some of these are the barriers that we have faced. We've had some issues with the laptops. We've only got a finite amount of them, but they're shared across our stores team topping up wards, and also the pharmacist team who are working on the wards as well. So from time to time you do find there's no laptops left, but I think Mr. David Smith has said that we're going to get some new laptops, so that's awesome. We've only just found that out, so that might not necessarily have to be on this slide. So hopefully we're going to get those laptops. We would like to have 2 mobile phones introduced to pharmacy stores as well, so that me and Danny can take a lot of the phone calls out of pharmacy stores and deal with those requests and queries just ourselves. Be that if we were on a ward, we'll get a phone call, we can deal with it with the laptop that we've got in our hand, and it'll just alleviate a lot of the pressure that's going on within our department, and it'll make that, obviously, again, they can carry on with their jobs, do it quickly in a more timely manner, and get the patients their medication as quickly as possible to the ward. We need some more project time, which we're working with our managers to try work out more time to be able to get this project to really bloom. We're only at the minute sort of having a half day here and there every week, or a day. I work up in the office, so I've had a little bit more time recently than Danny has, who's been supervising in pharmacy stores. So we really need that time together to be able to just push it more, because I think we could do a lot more, a lot quicker if the time was given to us. We want to work on a lot of the staff skills as well, that we have in pharmacy stores. As I say, in the previous slide, we've come up with a few hicks here and there with staff not wanting to change. We want to, empower the staff, make them really passionate about what they're doing, get them involved, and that in turn, it helps them, and it helps them, it might help them decide what they want to do in their career. You never know. What else have we got here?
This one here, I just want to go to this one that Scott's already mentioned about the project blooming. The time to train the ward staff, that's why we need more time as well, because the wards that do their own top-ups, I don't think they understand how a stock list works, or educating them and teaching them how to use a stock list properly so they're not overstocking themselves, that, with drugs and things like that. We want to get that passionate bond between the wards so they know they can rely on me and Scott to know that we're there to help them at any forgiven moment. That goes in with the mobile phones, and it all links into each other, that we want to really show the staff that we are there for them, me and Scott as a team, to help the team out. Because like I said, everyone works when we work together as a team. We work for the NHS, so it don't matter it don't matter what job position you're at. Like I said, Scott, we're all the same. We're all the same people. We all look after each other, and that's what it is. We all come to work. We come to work to look after each other and be there for each other.
Yeah. No, we're all obviously, we have our own lives. Some people come to work, they go home. That's how it is. But we spend 80-90% of his lives here. There's no reason for us to not want to make it better, and that's what we really want to push to other staff as well. That it's, we want to get them passionate and driven and enthusiastic and want to be a part of the changes that are occurring. And, and this is one way we can do it, just involving people in the project that we've got going on at the minute. We want to, like Danny said, we want to train the ward staff. The night staff in particular are a bit of a nightmare to obviously get hold of, because I'm at home with a beer in my hand and I don't want to be coming in at 1 o'clock in the morning to train anyone. So so we want to get that rapport and relationship built with the ward staff, the managers, the sisters, to really push through the changes that we're trying to implement are fundamental to their ward working in a better manner. And we want the staff to be trained exactly the same across the board on every ward. It's one process, and it just requires a bit of time and a bit of communication between the two of us to make it work. But the night staff are a bit of a nightmare to obviously get hold of, because it's up to the manager or the sister to implement that. I can't do that, unfortunately. We want to be sorting out the wards and the clinic rooms, obviously, making sure there's storage is correct and everything. We have found that there's a lot of insufficient space in a lot of the clinic rooms that are tiny for the stock that they hold, and there's not really anywhere else to put it but sort of cram it in cupboards. But this ties in with making sure that they've got the right amounts of everything, so it's not overstocked, it's not overflowing, and these errors don't happen where patients are given wrong medication. Anything else to add?
No, that's fine. No.
Next slide, please, Laura. Thank you. Do you speak about this? Or do you want me to speak?
Go on, let's crack on.
Okay, so these are the excess stock requests from the 5th to the 20th of February this year. This is on top of the ward top-ups that we do, or that the ward top up themselves. Some of the wards in the hospital do top their own medications up. That is also, again, leading to issues and problems, things not being ordered correctly or too much being ordered. So again, the training is an issue, and that should drop a lot of these numbers significantly once those staff have been trained correctly.
I mean, that's what we evaluate on this as well, everyone. The wards there that are in blue are the wards that do the we top up. The ones that are in red do their own. So while we had this from the 5th to the 20th, me and Scott have been to a few of these wards. So Ward 19, we've been there, and Scott's got a great relationship with the sister up there, Jane McNulty, and she's put into place that the night staff will not order on nights, they'll just order through days and as requested what they need. So then we're not getting excessive emails and things coming through. But since over the last, let's say, 6 weeks, 7 weeks, we've really got into it really. And these now, when we're going to do it again, and if we get a chance to show you again, which I hope we do, you'll see the reduction across. So we want to be somewhere down near the 2.4 mark. That's what we're aiming to get. So the wards that are above the 2.4 mark, we're aiming to get it down. So it's at a low, So we're not getting all these excessive stocks, and then we have to go sort it out again for them. So, but the wards are really on board with it, and we've got quite a lot of them on board with it at the moment. So we have seen the reduction so far.
Yeah, if we were to run this report again, I think some of these wards will have dropped right out of that first top section of this bar chart. I think we've really nipped in the bud a lot of the problems. 19 obviously is number one there. So there's 14 ad hoc requests that they've sent to us on top of the top up we've already done for them. So a lot of these are 14 incorrect requests. So when we get an email from Ward 19 saying we need 10 boxes of something, we're obviously not in a position where we're going to go up to the ward to double check that that's correct and that they don't have any left and they need it. We're taking that as face value. They don't have any left. Send them 10 boxes, but then that request may come again in the next couple of days. The next time we go up to the ward, they've got 30 boxes of one item. But this is the difference in sort of training and the experience and knowledge that the staff have on the wards. One staff member thinks it's okay to order in this manner, the next one order in a different manner, and it's about that training for the staff and getting them to really implement the changes that we're recommending to them to stop these requests happening, because it's obviously just extra workload for us, and it makes their lives a nightmare up on the board as well. Anything else?
No, that's me.
Next slide, please. Okay, so these are next steps that we want to sort of roll out. We want to increase the number of top-ups that are conducted by our trained pharmacy staff. So we've got a couple of new staff members in pharmacy stores at the minute who are sort of getting into the swing of topping up wards. We want to, obviously, long term, we want to be topping up every ward across the hospital, and pharmacy is in control of all of it, which totally takes off the pressure of a nurse or whichever staff member on that ward having to top those medications up. We want control of that. We can make sure that it's done in the right, correct way. And then there should be significantly less problems that occur now, or none at all. That's obviously what we'd like to happen. We are introducing Omnicell cabinets onto the wards. David, I don't know if you want to mention something about Omnicell to anyone who doesn't know what they are. Are you there,
Yeah,
David?
so Omnicell cabinets are just automated dispensing cabinets. So it's part of our scan for safety work to introduce those. We've got some going on live on Ward 2 in ED. And they will help improve the security and safe storage of the medication. I can tell you more at another meeting.
Okay, thanks, David. Cheers. Yeah, I didn't want to. That's as much as you'd need to know, I think, at the minute. If you want to know any more, you probably have to speak to David about that further. But that's going to have a big benefit to the staff on the wards, introducing these cabinets, and it also will us as well once we're trained up on how to use them. But that's something we'll get to in time. Anything else to add? No? We do need quite a lot of different sort of hardware-y things in stores at the minute. It's quite prehistoric, I'm going to be honest. In terms of technology, we are hopefully getting some laptops. We would like pharmacy stores, and we can deal with them ourselves. And that also gives a face to pharmacy stores as well, whether that is, delegated to me and Danny to be the faces of pharmacy stores, but it would be great to build those rapports with staff members across the trust, and having a familiar face and a familiar voice on the phone to speak to every time, rather than out of all of our staff it could be anyone, and you know, it's good to keep a good face and a good name to pharmacy stores. Our computer terminals and printers are really outdated. They crash pretty much every time that we use them. To print anything off, the computer crashes and we have to restart the whole thing again, whole system. So these are little things that we do need working on within pharmacy stores. We're going to try and make the clinic room on the ward a little bit more identifiable as a clinic room as well. But this is more tying into staff who are new coming into pharmacy stores, being able to locate where they need to go to on a ward to deliver medications, just to ensure that they're not delivering them into a wrong room, which has happened on occasion, not very often, but it does happen from time to time. Just making them more centralised and signposted area for our staff to be able to locate where it is they need to go on a ward. And we would like some access, if at all possible, to different staff forums. I don't know if that'll be, I'd heard that there was, used to be, or there is a nurse forum. I'm not sure if that's the case, but that I think would be really beneficial for us in terms of the project. But as stores, just, you know, if this project wasn't running, I think that relationship with you know, a forum of different staff members would be beneficial just to stores. It you know, it wouldn't have to necessarily be for this project, although it would work really well. But do you think you agree?
Yeah, definitely. Yeah.
You know, and different multidisciplinary teams, you know, be that doctors, you know, nurses, different ward staff, whoever, really.
Just one as well. Here's one thing that was put there. Like Scott was saying, Sad give us a deadline for the next steps and things like that in the slides. We're going to make, for the wards, we're going to make a pack for the wards, like a starter pack. So in that pack, it'll consist of how to store fridge items, do's and don'ts. There'll be an email example in there, how to normal email. There'll be a stock list in there. That'll be a brand new up-to-date stock list, which me and Scott have already sorted out with the wards. That'll be minus the modification that we do, like removing the stock off, adding the stock on. So we are in process of getting these packs to the ward. So every ward will have a pack. We'll get one of these booklets, and it just says, it's a pharmacy store booklet, but it'll say pharmacy store for ward so and they'll know how to, like a little guide. It'll be a guide from how to do things a little bit easier, a bit more simpler for them, and make it a little bit easier for us. Well, like for example, putting codes on for a drug that they need when they email us, so we know what we're going to get. I mean, it's easy sending an email saying I want lansoprazole tablets 30, but there's like might be three different types, so we need to know, specify which one it is that they need for the ward, so then they get the right thing and we issue the right thing out and not the wrong thing. And
I think we're at the end of the slides, aren't we there? Yeah.
Are you there, guys? Yeah. Fantastic, gents. Fantastic. Very well done. Very well done, honestly. Listen, Scott, Danny, fantastic that. What brilliant insight to bring to the attention of directors. Some of you non-executive directors, of course, we can't be on the, you know, on the site all the time, so we don't get to always hear that kind of frontline experience. Absolutely brilliant. And I'm the chairman, as you know. Can I compliment you on your leadership of running this project? Well done. And I just want to say, I'm going to open up for questions now, and we'll maybe direct those questions through David so that he has the chance to bring to our attention anything he wants. But can I compliment you as chair on the focus you've got on speed and efficiency to the ward? That is brilliant, because honestly, you know, whenever I'm hearing little bits of feedback, it's often about, you know, waiting for meds, whether it's from staff or patients. And the way in which you articulated the importance of a focus on patients was brilliant, and a credit to you and your department. So,
yeah,
you know, very well done.
Really appreciate that. Thank you.
Thank you very much.
Great insight. And I'm saying that all before, of course, I'm going to open up for any questions or points. To be fair to you, let's direct those questions through David in the first place. And if he thinks that you may have a perspective, that would be the way to deal with it, wouldn't it?
Yeah.
So, terrific stuff, guys. Absolutely brilliant.
Thank you.
Cheers, Max.
Okay. And you've obviously won us all over, because there's plenty of people who would like to. So that's great. So I'll go in the order I've got them here. Altaf, please. Scott and Danny, just so you know, you've got all the directors here. So you've got all the
Yes.
senior leaders of the organisation who very much enjoy hearing from you. So that's who we
Thank
are.
you.
Okay.
Cheers. Thank you, Max.
Shall I pass to you, please?
Scott and Danny, fantastic work. You can't be replaced. What you do can't be replaced by Omnicell cabinets, definitely. I've got 3 questions really, and they're just fairly broad. I mean, I think you've got stock overstocking issue really nailed and on its way out. Another sort of significant area of cost and waste in pharmacy can be operating a FIFO, where medicines are lost through expiry dates and have to be disposed of unnecessarily. So I'd like to know if we've got systems and process, maybe as part of Scan for Safety or work that's been done to assist with that. The other one is probably a bit more technical. It's to do with the what was the Falsification of Medicines Directive, where there was an effort to actually serialize medicines, and if something was counterfeit or not fit for purpose from a patient safety perspective, it could be identified through IT systems and withdrawn from pharmacy stock, and we could actually extend that traceability to a patient and actually recover the harmful medicines from them. I just wanted to know where we were there. Question number 3, and I will stop here, right, is vital area, discharge planning, and the work that you're doing with the wards and the multidisciplinary teams to provide medicines in a timely fashion. Again, is there more we can do in terms of technology and IT systems to give you better visibility and more of a closed loop around that, really? Thank you.
Thank you, Altaf. So with all questions, we'll run through David first to allow him to bring to our attention what you feel important, David. So, but that's not to diminish your role, Scott and Danny, not at all. But it's right that we let David deal with these first. David, please.
Okay, yeah, thank you for that, and thanks, Scott and Danny, for a brilliant presentation. Yeah, so first of all, there was the talk about sort of the stock management and the expiry dates. As part of Scott and Danny's work, they are reviewing the expiry dates of the stock on the ward as well. And by adjusting the stock list, we're making sure that the stock that's used there is actually used and doesn't sit in the cupboards. When we move to the Omnicell cabinets, that will also give us the ability to have a look at that and auto order the stock as well. So there's more work to be done there. Within the wider department, the wider trust, we have a full stock management system. So we do look to use first in, first out principles to try and make sure the stock moves through. So we try to minimise any expired stock. There is always going to be some wastage. So some people may start treatment within the hospital that then we can't use the rest of. And that does happen, but we try to minimise that as much as possible. But yes, certainly the guys at the stores guys are doing and looking through all those expiry dates certainly helps with a lot of that as well. I think your second question was on the Falsified Medicines Directive. We had a full plan for the Falsified Medicines Directive. We had a business case ready to go. Luckily, the Falsified Medicines Directive was going to cause us some significant problems. It was going to be a very time-consuming process. Because we've left Europe, we now, as a country, have decided to drop the Falsified Medicines Directive across the board. So we're not actually doing anything with that as a trust. So we're continuing to order the supplies from our suppliers. The suppliers we use are the main wholesalers or the suppliers that the drugs manufacturers tell us to use. So the chances of us coming across a counterfeit medicine are very slim. We don't use some of the grey market, some of the other methods of getting medicines into the trust. So I suppose while we could see what the benefits of the FMD were, they were going to be very costly. I think we estimated we were going to need something like another 6 colleagues at least, because it would require scanning everything in and then scanning everything out, and it was going to take a lot of time on that one. So I hope that answers your question. And in terms of discharge planning, technology and IT, this year, so there's two bits to that. In terms of the IT, this year there is a sequence connected to the discharge medicine service, and this is about communicating any changes to medicines to community pharmacies, so that they can then follow them up. The community pharmacy has a number of tasks that they can do that then allows them to claim for the discharge medicine service. So we are linking into that, and we already use that, but there is a desire to drive up the number of referrals we make. So we do that part, which is a communication outside of hospital. In terms of the discharge planning within the hospital, we've got a number of work streams outside of pharmacy stores that are going to look at how we can improve those processes. We're also going to run a pod campaign, which is trying to get patients to bring their patient's own drugs in. And I'm trying to get one of our colleagues to appear on Mel's weekly brief to update on that as well. And we're trying to get a piece in the media as well. The benefits of bringing your patient's own drugs in is that the patient has the drugs there already. So if it's something that would not routinely stocked on the wards, they've got it available. But also the patient's familiar with the tablets, because certainly with a generic tablet, the box that we supply might be different from the box that they normally get, and that could lead to confusion and people taking a medicine from both boxes when they get home. So there's a lot of benefits in patients' own drugs. So we are pushing a campaign on that. So I hope that answers all your questions.
Thank you, David. Thank you, Altaf. Is that satisfactory, Altaf?
Yeah, that's fantastic. Thank you.
Thank you very much. Yes. Yeah, I know this is taking time, but that's okay. This is important stuff. So let's do this. It's great. Karen, the mic's with you, please.
Thank you. Just a couple of comments and a question for David, please. Guys, I absolutely love what you're doing. So what really got me was the better patient outcomes to start with, but actually wider than that, taking pressure off nurse staffing and HCA staffing and other staffing that is really important, increasing in engagement and changes in behaviour as well. And you're absolutely nudging and influencing people. And overall as well, delivering financial value, which is great. So brilliant work, wonderful example of how small things make a huge difference. And my question, David, is I'd love for these guys to come along to the People Academy and tell a people story, because this story is really inspirational, very compelling. And I'd love for, as I'm sure everybody around this table would, for more people to be thinking in this way across the trust.
Thank you for that. Yes, and I'm sure we can bring Scott and Danny along to the next People Academy, and they can talk to this subject again. I think you're right. They're very enthusiastic. So yeah, happy to bring them along to the next one.
Thanks.
Thank you, Karen. Yeah, that's great. And I'll move to. So just bring the thing up. Yeah. So Julie, do please come in, Julie.
I'll be quick because my comments are very similar to Karen's. Loved the presentation, and I love the fact the money saver. So I chair F&P, so the money saving bit, fantastic. I just thought this embedded the values of Bradford without kind of saying it. It just was exactly about the values of Bradford and living those values. So really good to see. I love the fact, the ambition of the project. I love the fact you were measuring it, you were listening, you were talking to people. I suppose my plea is to the exec team, and I think people are already saying this, are there some of those barriers that we can solve? And I think some of the next steps could probably help with an exec team conversation. So that would just be my plea. But well done, guys. Enjoyed it.
Thank you.
Thank you.
Thank you.
Thank you, Julie, and well said. Yeah. And Mohammed, so we have Scott, Danny, we have a pharmacist as one of our directors. So I'm sure Mohammed brings a particular knowledgeable perspective, but I don't mean to put the pressure on there, but the microphone's with you. Thank you.
Thanks, Max. Hi, Scott, Danny. That was fab, actually. Really loved it. And one of the things I've been saying, I've been on the board for 3 years, is that I've never heard, I haven't heard enough about pharmacy. I've never had a pharmacy presentation at the board. So it's about time we had one. So thanks for doing that. something kind of you said in your presentation about the kind of the importance of medicines, and the most expensive medicine is the medicine that's not used, or the medicine that expires, or the medicine in the wrong place. And what you're doing is making that happen. So it's absolutely fundamental to the care that we deliver. One of the things that's often forgotten, I think, is that our biggest cost after people is often our medicines. So what you're doing is managing all of that cost on medicines, and medicines are critical to the delivery of care within the NHS. And the other thing I'd kind of say to you would, and I know you know this already, would be that kind of the biggest intervention in the NHS is medicines. And it's the thing we do more than anything else. And it's great that the pharmacy team are kind of taking the lead on this, which is the way it should be. I've got a bunch of kind of questions or comments, perhaps, Dave, and I'll fire them at you for now. And I know I've picked this up for you separately as well, but I do want to kind of just delve into this a little bit more. But the overarching thing, I think, is that I think we've really felt the absence of pharmacy at the board in terms of presenting to us and giving us updates. Pharmacy is so critical to the care that we deliver as an organisation. And one of my disappointments has been that we haven't heard more from the team. And I think we need to try and fix that. And I think what you've heard today is that we've really, valued the time we've had with you and your team, and we want more of it because it's so critical to the care that we deliver. A couple of things just to pick up on in terms of more detail. The Omnicell cabinets, really great idea, love it. But I've heard some interesting things about the interfaces and some concerns from other trusts about those interfaces. Particularly, I think in Newcastle, they've had some real issues about the interfaces. Now, I know there was a lot of push to kind of invest in the Omnicell cabinets because of capital costs and money has to be spent and that kind of stuff. But I think I've heard some real risk concerns around those interfaces, that they're not quite fit for purpose. And I really want to delve a little bit deeper outside of this session into the risks of those interfaces and making sure they're actually safe for patient use. The robot, when Max and I came to visit you a couple of years ago in the pharmacy, and we recognised, and I think Scott, Danny, you said kind of prehistoric pharmacy. Pharmacy is always a Cinderella service. It's always in the porter cabins or in the basement. It's kind of out of the way. And I noticed that your robot was completely antiquated, and it really needs refreshing and renewing. And it's not just important for efficiency and automation and staff well-being. All those things are really important, but it's really important for patient care. And we've had some errors that could have been fixed by using automation better, or having a better kind of automation built within the pharmacy. That robot, David, really needs replacing. And I know you know this, so we need to drive that change to make that robot fit for purpose, and so that all the medicines that can go into that robot, so we're not having people doing things that the robot's better at, and we get the people doing the stuff that people are better at. And I think that's really important for us to do. So Saj, I think we really need to look at that robot in pharmacy, and it needs to be a priority to replace that. The other big thing I wanted to pick up on with you, David, was multilingual labels. It won't surprise you because it's been something that I've raised with you before. I'm a little bit surprised that when we delved into multilingual labels, and I know you've been trying to do some work in this, but the work's paused, is that at Bradford, we've chosen not to do it. Whereas similar trusts like Luton, with a similar demographic to ours, have done, and they've implemented it, and they found huge value in it. Similarly, the Academic Health Science Network in Wessex, led by Claire Howard, who was the former deputy chief pharmacist, they're a real big advocate for this. They're really pushing it really hard. They think it's doable. They think it's deliverable. They think it adds value to their patients. But we don't seem to have really kind of engaged with it and pushed it, and I'm disappointed by that. I'm going to be having a follow-up call with Mary Evans, whom you probably know, who was the chief pharmacist at Luton, but is now on the board for the English Pharmacy Board at the RPS, and they've implemented it and they made it work. And I want us to be able to really understand the value of this and the risks in it, and engage with it. And I know in the written response I got, it talked about we see some real issue risks in this, and we think there's some technology issues here that we need to resolve. I want to understand why other trusts have been able to do it and we haven't. And yet, if I look at the demographics of our population, I could see real value here. So I'm really keen to explore that more and really kind of deep dive into why we're not doing this. But I don't think I'm getting a full enough picture. So that's kind of my little kind of soapbox around multilingual labels. And I'm not interested in, I'm agnostic on the solution we use, but I just feel it would add huge value. And as a patient, as someone who comes from a family where we speak multiple languages, I know that for my parents and kind of elderly relatives, it would add huge value to them. And not everyone can read the languages, but a lot of people can, and they can read it often kind of better than perhaps English. So it can add huge value. I'll park it there. But the key takeaway for me, for you, for David and Saj is, I want pharmacy to come back to us more often. There's so much happening in that area. We could spend, as we've seen this morning, we've spent so much time looking into it. There's a lot more we could look into. And I hope it's not 3 years before we see pharmacy back at the board.
Mohammed, that's terrific insight. Thank you. And what actually a kind of compliment to the idea of a collective board, the varied, diverse insight that we bring. Thank you. David, would you wish to make any? I wouldn't expect, of course, full answers to the very important points Mohammed's raised, perhaps as a way through Saj to maybe get together and deal with those. But would you wish to make any initial comments on what your thoughts might be on particularly the two kind of requests about the robot replacements and indeed multilingual labelling? Any thoughts, David?
Yeah. So I can pick up most of them, if not all. Yes, in terms of the Omnicell cabinets, we are aware that there are issues at Newcastle. As part of our project, we have paid a considerable sum to Cerner to develop the interface. So each iteration of Cerner is slightly different. So you cannot have a solution that works at one place that would necessarily work at another place. So we have engaged with that. We are quite aware of the risks of the interface with Cerner, but I think on a number of projects, unfortunately, the interface costs and perhaps responsiveness of Cerner are a concern. But we are working with Cerner and we are working with Omnicell. And we're working with EMIS, our pharmacy supplier, to make sure that those interfaces work. So we are aware of them, we are sighted on them. We have invested quite a sizable proportion of the money we've spent on Omnicell in developing that interface. So we are looking at that. In terms of the robot, the simple answer for the robot is the only robot that would fit in the space. So our space has numerous beams, air conditioning, and doors and things. We would love a new robot, but the sort of robot that we'd love to put in there is actually bigger than the dispensary. So we won't be able to put the staff in. So the plan for the robot is we move the aseptic unit out, and then we would put in a business case to redevelop what was the aseptic unit and put a brand new robot in there, but that would have to be a separate business case subject to funding. The robot that we've got still works. The dispensing error was not I think Mohammed is referring to, is not linked to the robot, it is linked to our process. And where you use a part pack, it doesn't matter which robot you use, where you use a part pack, it doesn't come from a robot. So that was linked to what we call our part packs. But certainly I would love a new robot, but obviously we'll have to go through the right hoops and channels and make sure the business case stacks up. In terms of multilingual labels, I think Paul's hand shot up here as well. We've done a lot of work with written medicine, and the guy in charge of it is a guy called Galib, and he's very passionate about his product. The last time we were involved in his product, and we were having detailed conversations with him, they didn't have an Urdu translation on there, which seemed to be fairly fundamental. There's also issues with how NHS England wanted it to take it forward in the interfaces, and the interface that written medicine has was not suitable for use with EMIS. So, and EMIS is our pharmacy system. So Galib did once say to me, have you ever thought about changing your pharmacy system? Which is a massive undertaking. So we did do a lot of work on it. And when Paul started, Paul was involved, and it was just something that we couldn't take forward here. The other things to mention is when it produces a label, if that label is in a different language from the language that most of our dispensers speak. So one of our challenges is how do we know that that label is then correct? Because whilst I can read 1-3 times a day, I can't read 1-3 times a day in the 85 languages that are spoken in Bradford. So we had real challenges there. So we have parked it until a better solution comes along. But I don't know if Paul wants to come in there.
Thank you, David. I was going to go to Paul on the basis his hand raised might have related to some of Mohammed's points. So, Paul, should I turn to you, please?
Thanks, Max. I mean, my initial hand went up actually to commend Scott and Danny, like everybody else, in relation to the quality of their presentation. And I'm not suggesting that everything that Mohammed has said is, good forensic inquiry around the way in which and the extent to which we use digital effectively in relation to pharmacy. And I mean, Mohammed will also know that my previous responsibilities meant that I've had pharmacy consciousness probably maybe higher as a CDIO than perhaps others have done. I think the right thing to do is to take the opportunity to strip all of those individual challenges out and to look at them in turn, both in relation to the written medicine piece with Gallup, to the piece around integration more generally. Colleagues in Calderdale have managed the integration with EMIS over the last period. We ended up with a challenge just from EMIS's perspective operationally to try and get that done in 21-22, but it's back on the work programme for 22-23. So there's a range of these things that we are making progress with. I wouldn't want Mohammed to believe that we have, or in any shape or form, continue to sideline pharmacy, because I mean his two earlier points about the criticality of medicine and the way in which we deliver care, and the point about the most, the highest level of waste is the medicine that is unadministered, are absolutely correct. Yeah, I think if it's all right with Mohammed and David, happy to commit to a session where we sit down and break each of those issues out in turn and see what progress we have made and what progress we can make. And then just to the fundamentals, and I appreciate it shouldn't necessarily take a board meeting to bring hone these things into view. I've already responded to Danny and Scott's frustrations in relation to both the laptops and the mobile phones by saying we'll sit down across the digital services team with them and work out what we need to do to remedy that in the instance. So yeah, fundamentally excellent presentation. It's a big topic. Happy to, and we'll continue to work with Mohammed, David and the team in relation to how we can use digital most effectively in this context.
Thanks,
Thank
Paul.
you, Paul.
Very helpful perspective, Paul. Thank you. Mohammed, shall I? Scott or Danny, did you want to come in, Scott or Danny, on this particular point? Were you needing to say something there? Sorry.
No, we were just saying thank you.
Thank you.
You've recognised already that we have an issue, and it's it's been addressed already. Okay. So that's awesome.
That's thank
you.
Yeah, let's give Mohammed the last word on his points here, because he raised some really excellent points. So, Mohammed, with you, please.
Thank you so much, Max, for giving me an opportunity just to come back on that. Paul and David, yeah, I think we're all on the same page. I think we all want the same thing. We just need to try and make some progress on this and really give a focus on pharmacy. And I want our pharmacy to be the leading light in terms of its technology, automation, and patient care. And I just think we can get there. We just need a bit more kind of focus on some of the areas. Just in terms of that philosophical issue around checking a language that you don't read. We use barcodes all the time, but the barcodes are not human readable. So no one can read those barcodes, but we use them consistently throughout the NHS and Scan for Safety and everything else. We use them in parallel with language that we understand. With the same issue in Wales, where Welsh is a national language, not everyone can read Welsh. They have the same issue in Luton and in Wessex. So this philosophical issue of having a language that the staff themselves cannot read, but it's one of multiple languages that's on there, is an issue that's been dealt with by the NHS across various different areas. So I think we can address that. It's not unsurmountable, but you will always potentially get that. You're never going to get a solution where everybody in your team, David, can read and speak every language that it could possibly generate a label in, or a patient can speak. So, but there are ways of addressing that, and other people have done it. So I think just a philosophical approach, I think we can address this.
Thank you very much, Mohammed. Mohammed, can I just make sure, do you feel assured that your points have been heard and that there is at least proper consideration of the issues you're making?
Oh, absolutely. No, I know that Paul and David we're on the same page. I think we just need to make some progress in the different areas. So yes, I feel absolutely heard. So thank you so much for giving me that.
No, it's very well put. And your articulation at the beginning there, Mohammed, of the importance of pharmacy and medication to overall healthcare was really well put. So thank you for that. Mel, shall we give you the last word of our directors then, please, on the issue of pharmacy and modernisation? Mel, over with you, please.
Yes, thank you, Chair. So Scott and Danny, I knew it would be fantastic because the reason why you're here is I bumped into these two guys on my way back from Fieldhouse, and we just had a chat. I said, where are you going? What are you doing? And I had a potted version of everything that you've just heard. And in that sort of 5 minutes, I think it was snowing at the time, guys, I seem to recall, I was so impressed by what I'd heard and the enthusiasm and the passion that I said, listen, will you come and talk to the board about this? Not because of the things that they were necessarily doing, and we've heard there's lots of sort of change and improvement and all the rest of it. It was the attitudinal stuff, the ownership, the responsibility, the autonomy, was everything, like Julie says, that just epitomised the values that we have as an organisation and that we are trying so hard to promote across the organisation. And I think hearing what a great idea, Karen, that Scott and Danny come and talk to the People Academy, because the more people who hear this, I think they will see actually that there is the permission for them to do what Scott and Danny do. You know, it's the Myram's Maxim stuff, isn't it? You know, real change happens in real work. The people who are doing the work need to make the change. So I kind of had a sense of that when I spoke to Scott and Danny, but I would just add what I've heard from them is even better than that, because what I also heard was their maturity and their insight into behavioural science. You know, people's attitude toward change, the recognition of how it might work in some areas, because you've got good leadership in others, it's harder and you have to hold a mirror up. And that level of maturity from both of you is just amazing. It's just textbook change management and a fantastic working example of it. So thank you so much for coming and sharing, and just keep doing it and more of it.
That was great, Mel. Thank you very much. Well said. Yeah, well said. And there you go, Scott and Danny, that's the Chief Executive Officer expressing her appreciation for everything you do, and very well put. To conclude this item, thank you, Mel. You reminded me about Karen's suggestion of the gents perhaps speaking with the People Academy. So that's great. Picked up on that. Thank you. And there were 2 points in chat, David, Scott and Danny, that we should just quickly pick up. Karen, our chief nurse, brought to our attention, terrific presentation. Great to see focus on staff, patient well-being, and additional focus on enabling time to care and money to be better utilised. Huge amount achieved. What more can I do to help put my backing behind a rapid rollout and promote the perfect clinic room? So you've got the chief nurse thinking about this here now. So Karen's saying that she's got a 30-minute drop-in with all ward managers and above every Monday, a Monday afternoon, and more than willing for perhaps you guys to join her and perhaps get further buy-in and support on these ideas. So you've got the chief nurse offering to speak with you about maybe you joining her and expressing the importance of tidy clinic rooms, and with the support and authorization, of course, of the chief nurse. So that's great. That's thank you for that, Karen. Yes. And there was just one final point of interest that our non-exec director, Sugra, brought to our attention, David. She points out that this week there's been media reports of medication shortages. And Sugra was just wondering whether, do you, as our head of pharmacy, anticipate any issues or concerns for us? David, shall I give you the microphone?
Yes, thank you for that. Yeah, I was just trying to type in the chat. So we have ongoing medication shortages that arise from the fact that the market is now a global market. So just like anything else, the global market means that sometimes there are issues with supply. Sometimes you will find that whilst you might have 5 different brands of a medication, they all share a core ingredient that is made somewhere in the world which has a problem. In order to manage that, we've got a team within pharmacy, within the stores, that help to look at that. We manage it at region and we manage it nationally. So there is one of the Deputy Chief Pharmaceutical Officers who is responsible for medication shortages as well. At Region, we have a system which allows us to see stock in every single trust, so that if I was struggling for stock, I can ring up Region and say, I need this, who has got this, and we can move stock around. And we've done that a lot during COVID and with vaccines. So a lot of the medication we used to treat COVID that wasn't originally developed for COVID was moved around as necessary to treat the patients. So there are shortages. It is a risk, and the risk sits on the pharmacy on the pharmacy risk register at the moment. We have escalated it in the past to the trust risk register when it's become more of a problem, but at the current stage it's sitting on my register because I don't think it's more significant than that. We have methods in place to manage it, and we keep managing it and keep reviewing it in that way. So I hope that reassures you that there are mechanisms in place to manage them. They are there, but we manage them.
That seems very thorough, David. Thank you. Sugra, can I assume that that's answered your question, please?
Yes, thank you, Max and David.
That's great. In fact, I see your comments in the chat there as well now. Yeah, thanks very much indeed. That's great. Okay. Laura, could we just pick up an action, please? There's been some terrific comments in the chat here. We've all been very taken in by this important presentation. Could we make sure that the chat transcript is perhaps sent to David and to Sarge, I suggest, just so they can pick up on what points the directors were particularly impressed by and noted. And I'm sure it would allow them to think carefully about the outcome of the presentation at board. That's great. Okay. And then I'll finish, of course, by turning back to Scott and Danny and give you the chance to, I'll unmute you, chaps. I think you can do that yourselves, can't you? It's your laptop there, yeah? I'll give you the last word.
Can you hear us? It says
Yes,
it's on
we do
mute.
fine.
All right, okay, great stuff. Yeah, just going back to what Mel said, thank you. We both of us really appreciate it. It's not often that, you know, I'm a band 2, Danny's a band 3. It's not often that we get the opportunity to come forwards in something of this nature. And, you know, we're speaking to the top dogs, and that to us, it means a lot. It does mean a lot to us. We've been really pumped up and hyped about it since Mel spoke to us that afternoon when she saw us. You know, and I'm sure we've been irritating our staff, banging on about it for ages as well. And we'll irritate them even more when we finish the meeting. So yeah, you know, me and Danny are really passionate. We're dedicated and driven. We really want to push this out across all the wards, and you know, it could go even further than that. What the work that we're doing for this project is a job in itself, you know, on top of the work that we're already doing in our actual job role. So, but we're really enjoying doing it as well. It's not that it's you know, I really enjoy doing it. You know,
it's the passion and the fire in your heart, and you got determination to do it. I mean, and what Scott was saying there, I would like to thank everyone as well, you know, on the board, you know, for having this great opportunity to come and speak to you, all you guys, about it, about what we're doing and things like that.
Yeah.
And there's one thing I'd like to say as well. Scott's mentioned it, Mel, Karen. When we're doing this project, if you'd like to come down to pharmacy, anybody on the board or whatever, and come with us and have a look at what we do, you're very gratefully welcome to come and see the process that we do, how we do things on the ward, you know, give you an insight into it and how determined and passionate we are when we're on the wards and how we are with the nurses and getting them on board. It'd be great to have you to come with us. We'd love it.
Yeah. Just finally, I just wanted to, I don't want to take up people's time that much. There's just a few names I want to mention because I think that they deserve a bit of recognition. It's not just me and Danny that are doing this. There are other team members who put in quite a bit of work as well. So there's Dominique Hallett and Dominic Priestley. They're our managers in the office. They've been a really big helpful, you know, support for us. Lisa Jameson, who's part of the quality improvement team. There's Stephen Anderson and Maggie Malloy, who are part of ICU, part of their team. And some of the pharmacists have been great. Chris McLernan, Ali Al-Embari and Raj Sohal have been awesome. Really helpful and nothing but, you know, positive and you know, willing to change since the beginning of the project. So yeah, thank you. And thank you all again. Thank you, David. Cheers. Thank you.
Well done, gents. Thank you, David.
Thank you. If you see us in the corridor, come and grab us. We'll have a chat.
We'll definitely do that. Listen, just let me reinforce for you, Scott and Danny particularly, you go from here with the full support of the board of directors, yeah? Keep doing what you're doing, keep being passionate about it, keep the energy up. When you think things aren't quite right, ask the questions, make the point and seek that information, because you'll be right. There will be something that just needs sorting. So, you know, obviously there are ways in which to achieve that, and there's elements of courtesy in that. But of course, you're doing a terrific job, and you do go with the genuine support of the full board of directors. So thank you. You've given us terrific insight. Well done. We'll let you get off to your rest of your day's work, okay? And David,
Cheers,
thank you.
Thank you very much. Cheers.
Well done, gents. Great stuff. Well, that was terrific, wasn't it? I think we were all pretty well taken in by that. Of course, we've run on, I know, and we'll be succinct where we can be, but I don't want to avoid stopping, pausing and asking questions during the course of this board meeting where we are. We've got plenty of time yet. We're going through to 2:30, but we have, of course, run significantly over there, but rightly so, rightly so. I want to be careful how much you say, of course, but there's maybe something about the level of the organisation at which we were hearing from there. You know, these are actually genuine frontline guys, aren't they? And the kind of insight and the honesty perhaps with which they were reporting to us was terrific. So really, really useful. And I hope colleagues will support my point about picking up on that chat, which there was a lot in there that I think Sarge and David will welcome, just to reflect on and think whether there's some actions might arise from that. But yeah, and there's a compliment to you as well, Mel, for when bumping into the guys, saying to them, you know, come along and speak to us. And indeed, they're clearly going to get other invites there as well. Karen, I'm delighted with your comment. Thank you about the suggestion that you might they might join you in a couple of ward rounds. So well done. John, you have a hand raised. Would you like to come in, please?
Thanks, Max. It was just to reinforce your point, really. I mean, I've made some comments in chat that I won't rehearse anyway, but I think this issue of visibility of the executive team to staff at that level is extremely powerful, particularly in the environment we're working in at the moment. Obviously, we've got to get the balance right because we can't get knee deep in the detail on every issue, but credit to you, Mel, for choosing this one, and I look forward to the next one as well. Well done.
Yeah, well said, John. Yeah, great stuff, great stuff. Okay. I also, of course, as your chair, will not forget that we just need to pause and maybe take 5 minutes to stretch our legs, etc. at the right time. So we'll do that in maybe, what do you think, next half hour or so, eh? We'll make sure that there's a break there. Of course, that doesn't stop anybody who needs to just leave briefly from doing that. Okay, but we're an hour and a half in, but that was terrific and gave me a lot of insight. So, and thank you, all of you, for the comments and insight you provided. It allowed for some prioritisation of thinking there. So great stuff. Okay. We got the next steps as well, so we know what's happening. And of course, we can pick up if you're reflecting on this later and you think, oh, just make that point. And I'm sure Sarge will welcome any future thoughts or comments and pass them through to the team running the project. Good stuff. Okay, let's go to section 2, deal with the minutes of our board meeting in March. May I ask whether there are any matters of inaccuracy or amendment that need to be noted, please? Just give people a moment to move on to the next bit. If not, can I take it that we are satisfied there a true and accurate record of our board meeting in March? It would appear so. That's great. Thank you. And with matters arising, there are 7 actions on our list, 4 of which are shown as closed. So I'll just pause a second and ask whether for any of those closed actions on the list, that's numbers 1, 2, 3, and 5, as you go down the table, can I assume that colleagues are happy enough that they are closed? Yep. And then the 3 with some action to consider are actions 4, 6, and 7. I'm talking about that coming down the list with number 1 being at the top. So action 4 is the Patient Recruitment Centre. And Laura, you've been trying to sort us out a visit to go and see the Patient Recruitment Centre later in this year. Laura, may I just ask whether, is there any update on that, or is that still something underway?
It's still to be arranged, Max. I think we've got the upcoming visits to the command centre and maternity EPR, so we'll look at this one probably for later in the year, if that's okay.
That's fine. So we'll leave that open, and hopefully we'll hear at a suitable time when we go see the great work that's being done there. Action 6 of the 7 on the list was the Partnerships Board, and this relates to the review and update of the mapping exercise, I think, of executive responsibility in our emerging partnership, which of course I'm very familiar with as well. John, I think you thought it might be useful just to remap responsibilities in relation to the partnership. Is there any progress to report there, please? I can see that the action does say to be completed by the end of this month, but may I ask whether there's anything to note?
It's still a work in progress. It's ICS and place. We're just looking at the new governance infrastructure and making sure we've identified where execs are involved, just so that we're all clear on it and we can manage any capacity issues. So we're doing it. We haven't completed it yet. We'll circulate as soon as we've done it.
Thank you very much indeed, John. So again, we'll just leave that open, and thank you for that update, John. The last one does have an October timescale, but it was the very sensible suggestion that we might wish to spend some of our time on a development session thinking about maternity services updates. Clearly with Ockenden and the assurance required regarding our own CQC position, etc., and the work we're doing to produce an outstanding maternity service, it can be quite transactional when we're meeting together as a board, of course, and Sarah does a fantastic job, doesn't she, of bringing together a huge amount of data, bringing to our attention the key things. But may I just ask Laura again whether, or indeed Karen Dorber, is there any progress yet as to whether we might have some time just to kind of deep dive into how we're doing on maternity? Laura?
It's on the list, Max. I think I've got we're meeting you and Mel later today, so we can discuss them if we want to plan it in.
Perfect. Yeah, no, that's absolutely fine, Laura. Thank you. So, and Karen, I know you were available there, but I think directors will be assured and satisfied that that's on the list and that we're going to do that and just spend a bit of time reflecting and thinking and monitoring progress. Other than with the significant amount we do, of course, here at board. Okay. So that's the situation with the 3 outstanding actions, which are all well underway. So thanks, everybody. Okay. Moving to section 3, the first of those items is the report from the chairman. Can I assume, I think I've probably spent enough time talking, haven't I, but can I assume that colleagues have read that report? Much of it focuses on our relationship with our important relationship with our governors. I should thank everybody for the excellent Council of Governors meeting. Again, there was a very good director turnout, well, a terrific director turnout, as always, at that. So thank you for everybody for the Council of Governors meeting on the 28th of April that was taken there, and indeed the ability to manage all the questions that were raised during the course of those discussions. You'll recall that there's often a lot of discussions arise between governors and non-exec directors at first, and non-exec directors give the information, but we would always want to check that with exec directors, and that went very well. Pat, can I compliment you and Fahim? Thank you for the single question that required a little more detail on issues of temporary contracts here at the Trust that were raised by governors, and I've seen the draft response to that, which gives a great deal of detail and is terrific, open and transparent. Pat, can you confirm that that has gone now, or is it about to go?
It's about to go.
Right, that's
yes.
Fine.
Yeah.
Thanks very much, Pat. But that was a good response to an interesting point about the number of people that we might have on fixed or temporary contracts here. And I think it was thinking about looking after our workforce. Very well made point, and we'll make sure that that's copied to directors as well. There's nothing arises from that I would bring to your attention of concern. In my report, let's focus on people. Can I invite directors to join me in sincerely thanking Stella Hall, Hardef Sohal and Wendy McQuillan, who have spent a great deal of time serving this trust as governors. Indeed, 9, 15, 21 years between the 3 of them here that they've given in an unpaid role, of course, let's remember, giving time to the trust and supporting us. So I'm sure you'll join me. We will be properly saying goodbye to them, of course, at an event to come in the near future. But terrific people, significant experience, and have led and steered us extremely well. And just sticking with people, and I'll stop there, is of course the lovely news that the Council of Governors, through the Nominations Remuneration Committee, unanimously invited Julie and Mohammed to stay with us as non-exec directors for a further period of 3 years. So I was delighted to be able to tell them that. And of course, there are closed discussions about that in the first place, but then it comes to Council of Governors, and there was unanimous support for us keeping hold of 2 terrific non-exec directors in Julie and Mohammed. So I'm pleased to bring your attention to that, and thank you to the governors for the right decision and a sensible way forward. So thanks, everybody. My report, of course, colleagues, doesn't include some of the details of the local and regional partnership representation that I get involved with. And indeed, I will be chairing the Bradford District Partnership Board in June. So for the next meeting, in the absence at the moment of the appointment of an independent chair. We're on with that. But of course, Mel is place-based lead, and she and I have discussed the agenda with some of the governance colleagues, and the middle of June, I think it is, will be the next partnership board, and I'll be in the chair for that. Okay. In the absence of any questions, shall I move to Mel? I don't think there's any questions required, so as to note the report, thank you. Thanks again to governance colleagues who produced a draft for me with that. And I'll turn to Mel and hand you the mic, and the floor is yours, Mel, for what you would wish to bring to our attention.
Okay, thank you very much, Chair. I will start with our sort of strategic priorities around patients, first and foremost. Our COVID numbers of inpatients continue to slowly decline, with today 23 patients occupying inpatient beds. The general trend for our COVID patients in not requiring as much intensive care support also continues, although there are some still exceptions to this, with a smaller number of patients requiring respiratory support, just one of those today of those 23. Being able to consolidate our COVID inpatient numbers into one ward area, and that is Ward 31, has given us much greater resilience and continuity to our elective recovery programme, and also greater flexibilities in being able to meet what has over the last 2 months been an unusually high level of sustained demand upon emergency services, with a significant proportion of days exceeding over 400 attenders via our A&E department. We continue to monitor the emerging guidance in relation to infection control measures, and in line with that, there has been a gradual but cautious relaxation of some of these, whilst certain restrictions, particularly in clinical areas, also do remain, including restrictions on visiting, towards which we're taking a measured and proportionate approach. On the 14th of April, we had an extraordinary meeting of the board in which we reviewed and approved our organisational response to the operational guidance for 2022-23, which has now been submitted via the ICS. And we are now clear on the operational plans we have to deliver and the resources available to us to deploy in the execution of those plans. Moving on to people, I'll start, Chair, if I may, on this, Florence Nightingale's birthday, and therefore the annual International Nurses Day, by wishing all of our nurses across BTHFT a happy Nurses Day and thanking them for all the amazing work they do, not just, of course, today, but every day. And I'd like also to pay tribute to all our midwives, who also last week celebrated National Midwives Day. I hope colleagues have managed to see some of the BBC Two documentary Yorkshire Midwives on Call, 5 episodes featuring our home birth team, which I think gave some incredible insights into the role of our midwives, just a small proportion of our midwives, of course, and the phenomenal personalised, compassionate care delivered by that team that I think are wholly representative of the totality of our midwifery workforce. Staff survey, Chair, you've touched on and will appear later in the agenda where we will hear some of the detail, but the headlines are essentially disappointing and perhaps not entirely unexpected given the timing of the survey and the respondents being in the middle of a peak of the COVID pandemic. We saw a deterioration in the satisfaction of our colleagues across a range of measures. This was consistent with the national picture, and it's clear that when we use the words restoration, recovery, getting back to normal or business as usual in relation to the provision of services to patients, that as importantly is the need to focus on how our colleagues are feeling, their well-being, their resilience, their fulfilment and enjoyment of their roles, the value and recognition attributed to them, and the level of engagement and influence they feel they have over what it is they are being expected to do day in and day out. Something that we have and will continue to make a focus of our People Academy. And I know in that regard, as you've already heard, both Karen and Ray will be lending their support to the mental health event orchestrated by the outstanding theatres programme, and will be over in the Sovereign Lecture Theatre, making it known to all our colleagues the importance that we place on good mental health and well-being. Something I think that will also help us to better connect and work with our colleagues. An example of which you've seen today through the presentation that Scott and Danny have made is to have the presence of good, effective staff networks. And whilst we have had 3 staff networks in existence for a while now, the Race Equality Network, the Enable Network for those with a disability or long-term condition, and the LGBTQ+ network, as part of our Equality and Diversity Council work, we instigated a reset of these. And yesterday, these were formally relaunched, and already we have seen a significant increase in the amount of interest shown by our colleagues in joining, participating and leading these networks, which I really welcome. In relation to our partners, in the past month, Chairman and myself attended the committee in common for the West Yorkshire Association of Acute Trusts, and as well as hearing updates on the various work programmes, including digital pathology, radiology, elective recovery, pharmacy aseptic prevention, we also received an update from colleagues from the Cancer Alliance, whom we and all other acute trusts across West Yorkshire are working closely with to design an effective, robust and resilient non-surgical oncology service across the whole of West Yorkshire footprint. Both Saj and Ray are involved in the work, along with colleagues from Airedale Foundation Trust, with whom we already have close working relationships and a jointly operated service. In place, the Health and Social Care Bill has received royal assent and has become law, and the transition path towards the 1st of July date to enable the West Yorkshire ICB to be formally established and constituted, along with the parallel arrangements which will see the Bradford and District CCG become the Bradford District and Craven Health and Care Partnership, of which I will be the lead officer, continues. The recruitment of an independent chair is in train, with an interview date scheduled for the 10th, which will be the panel, but the day before, colleagues will be invited, some to participate in a stakeholder group as part of that recruitment process. There has already been a first shadow meeting of the Integrated Partnership Board, chaired by Andrew Gold, in the absence of a nominated independent chair. And the second one, as Max has alluded to, will take place on the 14th of June and will be chaired by Max. Max and myself, as members of the board, have attended also a couple of development sessions as this newly established board seeks to fully understand its roles and responsibilities as a subcommittee of the West Yorkshire ICB ahead of the July go live. I think this is a really exciting time for our district, a real opportunity to improve the health outcomes for our population, to tackle health inequalities with a focus on prevention, help create resilient communities and provide high quality, sustainable, integrated health and care services to better meet the needs of the people whom we serve. And finally, Chair, I would just like to thank Altaf, who has helped us to create a first for us in the Trust, an event that saw Saj and John and myself this week come together with almost 50 of Bradford's most influential business and sector leads from across the Muslim community at a post-Eid event. I presented some context around the work of the hospital. We shared a video describing the work of the hospital charity, and we facilitated discussions at round table about how we can create constructive relationships, make connections, build synergies and action. This isn't and wasn't ever intended to be just a fundraising event in which we as representatives of the hospital charity went to connect with those business leaders. It was more about our relationship as an anchor institution, a way of better connecting with influential voices across the city, and to establish areas of mutual benefit for us to work collaboratively together with this really important group of people. And it was a hugely successful and very, very interesting evening, for which Altaf was first and foremost helping make the connections, make the interventions, the invitations and brokering those people after a very, very busy day that they all must have had in their respective roles, come and commit to several hours of time spent with us, learning more about what we do as an organisation and how we can work together to support one another. And I thought it was really, really good. Thanks ever so much for that, Alta.
Thank you. Thanks very much, Mel. Oh, repeating back, Alta. And I'll repeat and endorse your thanks to Altaf for pushing us and helping us make that move. Altaf, well done. Well done. That's great. Okay, so now, again, a great job of taking us through kind of from partnership, wider perspectives into what we're actually doing just here in the Trust. Shall I open up for any questions, thoughts, comments, queries that any of us may have of our CEO, please? No, have we feel well briefed? That's great, perfect. Okay, thank you, everybody. We'll move on then to section 4, delivery of the Trust's clinical strategy. So, John, could I turn to you then, please, to introduce item 8 and talk us through the board assurance framework and high-level risks. And I guess, John, you'll be orientating us towards a slightly new way of thinking.
Yeah, exactly that, Max. Thank you. So we've got two things in front of us. We've got the board assurance framework, the high-level risks. I'll start with the board assurance framework. We, as a board, had a really good development session on the it was last month, sorry, I've lost the date, it's just gone from me. A really good session on the 14th of April, where we worked through the new format of the board assurance framework. I think we all agreed that we found it a more helpful format, but there were a couple of small changes that we wanted to make. Those changes have been made. So the BAF you've got in front of you today is the new format. So we're using it for real as our board assurance framework, but in the interests of kind of full disclosure, I have to say, it has not quite completed its formal ratification yet. So the audit committee would like one more pass at this, which they're going to do later in the month. And then we will bring it back along with risk appetite statement and the revised risk strategy to the board for final sign off in July. But I'm grateful to Max and Barry and Julie for being pragmatic about this and saying, look, we don't want to go back and use the old BAF format today when we all agree this is an easier one to use. So you're looking at the updated format. You have on the front page a summary of all of the strategic risks and their current score, and in time you'll be able to follow the trend of what's going up or down, but obviously as the first time you're looking at this, there isn't a trend to follow. The highest scoring risk you'll see there is 2B2, which relates to continuing impact of COVID and the backlog and how potentially that gives us challenges in terms of performance. So you can see the strategic risks highlighted. They've been moderated by the executive team, so we think the relative scores are about right, and we think we've got the right range of risks here. Summary on the first page. On the next page, you've got the heat map, which tells you in terms of the current risk scores, how we're looking. And then underneath that, you've got the detail of each of the individual strategic risks. One of the benefits of this BAF, I think, compared to the previous format, is this does a better job of disentangling what's truly a strategic risk that we need to be looking at as a board because of the duration of the risk or the strategic nature of it, versus the operational risks, which we cover in our high-level register that I'll come on to in a moment. So for each of the strategic risks, there's a bit more detail underneath this front sheet, and you wouldn't expect that to change rapidly from one board to the next. You know, it's not as volatile. These are strategic enduring risks. So it's a new format which is yet to be finally ratified, but we think it's the right one. We've presented the risks in this format. Execs have gone through and provided the detail. We've moderated them. And I suppose I'll pause at that point, Max, less to worry about the format and just to say this is the first time you will have seen it fully populated. And the question in terms of the current position is, are you happy with the actions to address risks, that we've scored them correctly, and that we have a good grasp of the strategic risks facing the board? I'll pause there and then I'll come on to high-level risks in a second.
Thank you very much, John. Just a reminder then to director colleagues that we're being asked, of course, to note the latest position and the next steps, to review the BAF and satisfy ourselves that that's an accurate reflection, and to note the high-level risk register. So that's going to be the ask of the board, just to put in context John's helpful points. So I'll pause and ask for any questions now. So Julie, would you like to come in, please?
I just think it's important to say from the audit committee perspective, the only reason we didn't approve it, because although we got reassurance that we wanted some changes making and the changes were being done, we didn't actually see the finalised document. So the only reason audit haven't approved it is because we'll go through the proper process of seeing it and then being assured that those changes have been done. So I just think it's important we note that. It's the only reason it hasn't been approved is because of timing.
Yeah.
Reassurance versus assurance. Okay.
Good point. Yeah. Thank you, Julie. It's us keeping to proper governance, but you're absolutely right. Thank you. Yeah. And were there any other points anybody would wish to raise in the context of John's points? No, we're happy to hear any further detail you'd wish to direct us towards, John. Thank you, Julie.
All right. In which case, I'll move on from the board assurance framework. And of course, in the course of this discussion today, there may be things that come up in other areas, and that will have an impact on the board assurance framework. And that's how this should work, that we circle round and we pick things up. So the other item here is the high-level risk register, which you will be much more familiar with seeing. We've enclosed a summary of all of the open risks scoring 15 and above, and we've given you the movement log, all of which has been reviewed by the executive team and by the academy. So it comes to you here today, having had several passes already. It's a summary of the operational risks. So these things have been escalated on account of the score, and the same kind of moderation has taken place. As an executive team, we've been over them to ensure that we think they are reasonably and appropriately scored. Again, the highest, these are all between 15 and 20, and as the movement log highlights, one risk has recently been escalated up to a score of 20. Otherwise, you've read the papers, there is nothing remarkable here that I want to draw to your attention. It is the summary of open operational risks.
Thank you very much, John. Yeah, and so again, this is the perfect opportunity for colleagues who have read the papers, the board assurance framework and our risk register, to ask any questions they may wish to, or have they identified any gaps, etc., or indeed required further detail on mitigating actions. And I think we're being asked, and I think colleagues feel okay, they're assured by what they're seeing there. No need to ask for any further information. We're asked to note the latest position, review that BAF, and note the high-level risk register. We're content that we've done that without further detail required. Yeah, it would appear so. That's great. Thanks very much, everyone. That's good. Thank you. And thank you, John. And yeah, this will work for us, won't it? Julie makes the good point. It's just a case of the proper governance processes through audit committee. And that's right. That's exactly what audit committee are there for. Thank you, John, and thank you, colleagues. We'll move on to, we're going to take an update on our mental health strategy. I'll just check whether has Sarah joined us.
She's with me in my office, Max.
She's with you now, is she?
Yeah.
Fantastic, that's great, yeah. And then obviously we'll, I do want to be able to just take a moment on procurement strategy and make sure that we're properly satisfied with that. I suggest that if we deal with these two next matters, we'll take a short break and we'll come back onto academy business. And Laura, I'm conscious that we have two guests joining us during the quality session of our academy business. So I propose that we move first to quality and deal with those before then coming back to finance and performance. And thankfully, I've got Julie's permission for that through WhatsApp. So I did check if that was okay. It's not something I'd prefer to do, of course, but it's right that if people are expecting to join us at particular times, then we try and get as close to those times as we can. So that's the plan. We'll deal with mental health strategy and procurement strategy now. Take a break, come back to academy business. It'll be quality academy first, please. Okay, so shall I turn then to our chief nurse, to Karen, and to bring to our attention what we need to think about with our mental health strategy. Karen, please.
Thanks, Max. I'll hand over to Sarah and swap places. If somebody could share the slides, please, that would be really helpful. There's just a few slides for Sarah to go through with this update.
Thank you. Good morning, Sarah. Welcome.
Good morning. Happy Mental Health Awareness Week this week. So it's quite nicely timed, isn't it, really?
Yeah, perfect.
This is just a reasonably brief update, if you like, on the mental health strategy, which we launched last year. So the first slide's really just to refresh kind of what the objectives were and what our priorities were going to be. So there were 4 priorities that we identified, and they were in line with the district strategy as well, and the 5-year forward plan, and lots of national strategies. So our priorities we identified as training, workforce, information sharing and partnerships. Sorry, I'm on a different slide. Next slide, please. Yeah, there you are. So that was the original strategy that we launched last year. Next slide, please. So just some brief figures. Where did this come from? Approximately 1 in 4 people in the UK will experience a mental health problem. I mean, that's reasonably old now, is that? I think given the last 2 years, we're probably nearer 1 in 3, if not potentially 1 in 2. Patients with mental health or an illness diagnosis are at 3 times greater risk of premature death and a reduced life expectancy of approximately 20 years. And as I said last time I delivered it when we launched the strategy, I've been a mental health nurse for 25 years and those stats haven't changed in that time, which I think is damning, really. And suicide accounts for 25% of deaths. During COVID, the World Health Organization identified that there's been a 25% increase in anxiety and depression within the population. I don't think that's unexpected. I think we all know the reasons why that. There's been lots of things that have contributed to that. And I think we see that in our workforce as well currently. So next slide, please. So what we've done in the last 12 months, we didn't have any specific training packages around, so we've developed a level 1 e-learning package. Ash Greaves, who's our mental health specialist practitioner, devised that, and that was rolled out towards the back end of last year. Certain staff have undertaken de-escalation and restraint training. So my team have done that, some from Children's have done that, specifically in response to some of the challenges that we face with escalating behaviour from people in distress with a mental health diagnosis. And that was really to support security staff in how they respond to our patients who are in a mental health crisis. We've provided mental health first aid training for staff. Again, really important that staff can recognise their colleagues in distress with mental health problems. And we're hoping to run that again this year. From a workforce point of view, like I said, our specialist practitioner came into post in February last year. OD and occupational health have done lots around the Thrive initiative, wellbeing. We see lots of things in global emails, signposting our staff to support, be that apps, online or physical support. I know occupational health have offered a lot of psychology support for staff who may be struggling with their mental health and wellbeing following the pandemic. Information sharing, we've got some templates on EPR now specifically relating to mental health, which is helpful. We've explored some of the ones that were already existing and we didn't use particularly well. We've got an electronic referral system specifically for mental health referrals to the specialist practitioner. So they've had 181 referrals since it was set up last summer. So that's really good, shows that it works really well, and he's been able to do some really good targeted work. And for some of us, we've got System 1 access, which has been really helpful in understanding baseline for some of our patients who come in, who may be distressed, so that we can understand better how to support them more quickly when they access our services. And partnerships, we have regular meetings with BDCFT, and they've been really helpful across the board, really, on all levels. We've had exec-to-exec meetings, we've had operational meetings, some of their operational managers attend some of our daily huddles. So I think those, and I think one of the biggest changes has been how good those relationships have become now, how solid those relationships have become, and how quickly we see results when we start talking more effectively to each other. Core 24, which is the national initiative, regarding access in acute services to liaison psychiatry, that was agreed last year. So we've been in the process of recruiting, looking at going through that implementation plan and what that will mean for the organisation. That will have an impact on what we currently offer. It will be an improved service. It will mean that we have an on-site psychiatrist, which I think is wonderful. We'll have access to clinical psychologists. Again, brilliant. That response time will be much improved. So we're looking at a 4-hour response for an emergency referral. I think it's a 24 or a 12. Sorry, I forgot my numbers. For an urgent. So again, those are much improved, and it won't just be in response to what it currently is, which is usually self-harm. There's an in-reach service, so people with a deteriorating mental health will be able to access that service again, which is, again, like I say, an improved position from where we are now. Next slide, please. I just put this on because this is an example of what Ash has done since he came into post. So there's a lovely picture of Ash, bless him, on that newsletter. He does quarterly newsletters, and we really try and focus in on things that are helpful to staff. But also that actually, if you gave to a patient, or if a patient asked to see it, it'd be all right for a patient as well. And I think that's really helpful. So we talk on this one particularly, talks about, escalating behaviours and what you can do, what you need to consider. Really basic stuff, but really helpful for staff as a bit of an aid memoir, really. Next slide, please. So moving forward, again, within the priorities, I've put there for conflict resolution, de-escalation and restraint to be a high priority training, and a specific training post to be developed. I think one of the things that we regularly come back to when mental health is mentioned within the trust, be it an SI or an incident, or just generally if we're concerned, tends to be our ability, or our staff's ability, to respond in a way that's appropriate before it gets kind of up here somewhere. So where, those steps in between. I think we all recognise that the de-escalation is really, really important, that often, in some cases, we contribute to escalating behaviour, not deliberately, but because, people get frustrated, we don't pick up on signs and symptoms particularly quickly, people get frustrated and we don't respond to that in a good manner or in a timely way. And so I think for me, one of the key things that we really need to get focused on and get sorted this year really is that training post and getting that good de-escalation training rolled out. Restraint's another matter, and as most people who know me, when I talk about restraint, I'm not keen for us to go down a restraint route. I think there's a place for it. I don't think an acute hospital is necessarily the place for restraint, but I absolutely think we need to make sure that staff are safe in responding to those really tricky behaviours. Also, we've had conversations with Bradford University, so they now provide a 4-year course where you will be dual qualified as a general nurse and a mental health nurse, or a children's nurse and a mental health nurse. That's brilliant. I think that's really good. The next conversations are around, can we then devise a top-up course so that some of our staff can access a 6-month or a 12-month top-up course to their existing qualification. I think that'd be really good. I'd be really interested in doing it the other way and doing a 12-month general nurse top-up. But I think, you know, that's all really empowering for staff. Also, the conversations around modules accessible for general staff to do mental health modules with CPD credits at the university again is all in conversation and would be really helpful. From a workforce point of view, again, the conversations that we're having currently around how do we get more experienced staff around mental health within establishments. So be it mental health nurses, be it healthcare assistants, how do we get them in establishments in key areas? So A&E, AMU, places like that, where that kind of different way of thinking would have a real benefit for patient experience. As we know, recruitment across the board is a challenge at the minute, but it is certainly something we cited on and I think would be really helpful. And obviously, there's ongoing work for support for staff as the event today and Mental Health Awareness Week always helps highlight those things. And I think, like I say, occupational health, the global emails, OD have done a great job on signposting staff to other services that can support. From an information sharing point of view, we need to do more work within EPR. We work on different systems to the Care Trust. That does cause some challenge. You know, we can't get away from that, but there are things we can do within EPR. I think we have to be clear that we don't replace mental health services. We're here to complement and support them. So I think there's always a balance to be had between when we talk about risk assessments. You know, our staff have got to be comfortable and understand what a mental health risk assessment looks like and is it fit for purpose in this environment and all those kind of things. So they're the conversations we're having at the minute. The ability to access mental health paperwork in EPR would be really helpful. And again, that's something that we're looking at. It's a real tricky thing legally if paperwork goes missing or if it's not accurate or, you know, there are any discrepancies in it. My team currently manage that. I think just getting it electronic, it just makes life much easier, really. And we're looking at a shared referral with the PLN. So we've currently got the psychiatric liaison nurses who work on a telephone and paper system. And what we want to do, they have access to EPR, is get a shared referral system. So it comes to my team or children's and it goes to the PLNs at the same time. And therefore, we kind of all are aware of the same people at the same time and the same concerns. From a partnerships point of view, like I say, the implementation of Core 24 is due to be embedded by June, July this year. So staff have been recruited. They're currently just going through that recruitment process. Everybody should be in post by June, July this year. They're going to be sited over by the Cancer Centre. They're going to be co-located with the MASS team, which is the voluntary sector support services. Again, I think that will have a massive impact on our ability to respond quickly to patients in mental health crisis and be able to make a much more smooth transition back into the community, because one of the things we know is that sometimes patients often get stuck a little bit because in trying to access appropriate services. So hopefully that will smooth that. I'm really keen to get some patient engagement and involvement in service development in the next 6 months as well. It's the one thing that I know we've massively struggled with through COVID. I'm really excited on that. We've got some really good links within the Care Trust, within Signet, within voluntary sector, and the plans are all there now for us to start engaging with patients to say, you know, when you came in, did you feel safe? Because ultimately that's what we want people to be. They want to be safe and they want to feel safe when they come into hospital. Again, like I say, we're not here to solve all the problems, and certainly, you know, we're not necessarily here to treat mental health or mental illness, if you like. You know, there are services for that, but we absolutely need to make sure that people who come in feel safe, they're in a safe environment, and they feel confident in the people who are providing their care. Yeah, and I think that's probably it from me in a nutshell. There's lots of things I could talk to you about in relation to mental health, as most of you know, but certainly the vision for the next 6 months is that training, staff awareness, staff support, and making sure that patients are engaged in helping us design services.
Sarah, that's great. Thank you. That's a really great briefing, and thank you for what you do, of course, in this hugely important area. So a reminder to director colleagues, our vision is to promote protect and improve positive mental health whilst providing outstanding physical care. Promote, protect and improve positive mental health. Great stuff, Sarah. I just had one question, which was to do with how connected we might be with the bigger strategy across the partnership, for example. So, you know, Bradford and District mental health strategy. So do you feel that have we got a good relationship with partners? Do we perhaps share our strategies? Do we discuss our strategies with those partners and try and have them working well together?
Yeah, so our strategy was very much based on the district strategy, so that we could try and align some of those work streams. Really, we have, I would say, we have very good relationships with partners. I think we have very open and honest relationships. We've got very good communication links, and I think we've been able to have some really difficult conversations with partners when issues have arisen, but we've come to a good outcome, which has always been around the best outcome for that patient, and that can only be positive. I've seen some really good examples, certainly within the last 3 months, of, you know, where we've been having 8 o'clock meetings with senior managers elsewhere every day for 2 weeks to kind of go, come on now, what can we do? What's the next step? What are we going to do? And I think that's really important, because we know we're not here to replace service. As I said, we're here to complement service and make sure that we work together, so that if there's a sticking point somewhere, how do we fit in to enabling that to be unstuck? And we know there are challenges in children's social care. We know that mental health, children's social care, you know, there are shortages of placements which cause delays and all those kind of things. But the important thing is that we have the open conversations, we have the open dialogue, and we have trusted relationships, really. And I think we do.
I'm really pleased to hear that. Thank you, Sarah. That's so important. And Sarah, you might be aware, in my previous role, I was a West Yorkshire police chief, and I used to see strategies that clashed with each other between local authorities, etc. That's some time ago, to be fair, but and that's when it doesn't work, when people pretend they've got a great strategy and haven't taken into account the key people that you were working with. So I'm assured by that. I'm not suggesting there won't be occasional barriers or hurdles or difficulties, but I'm delighted to hear you, and especially that our strategy is in keeping with the overall partnership strategy. So well done, and thank you for that. Yeah, I'll open up for any questions or thoughts or comments. I think we've simply been asked to note the progress that Sarah's advised us of. Janet, please do come in.
Just a quick question, and thank you for your presentation. And I'm particularly interested, as an employer, how we learn how to recognise. I'm going to focus on staff for the minute, but it's people in general. Those who are on a trajectory to crisis, and you've already alluded to, you know, it is difficult. You know, those check-ins are difficult to actually manage. And I'm just here thinking about, you know, the staff survey results, where we are now in this present time, and it's almost we're in a critical situation to implement some of that training that you're mentioning. So it's reassuring that it's high on your agenda. And I'm also interested in the new roles developing. And I you know, in the dual role, which is great, there's a number coming across the country, which is really good. How, as an employer, we will create roles across, and it might be across the place, these roles emerge for these colleagues with the dual role. And are you engaged in that trajectory too, I think is what I'm asking.
So I think it's always a tricky one, isn't it, really? So I suppose coming back to that bit, I've been a mental health nurse for 25 years, and I sometimes get a little bit frustrated and have to manage my frustrations that mental health nurses are seen as not having general skills. So I think there's a bit of a mind shift that needs to happen as well. And we do discuss that. We discuss that a lot when we've been talking about how do we get mental health nurses embedded within establishments, because I think there has been a little bit of a block of, well, you can't do these things. Well, I can, because my mental health patients have heart disease, probably because of the medication we've given them for donkey's years. They usually smoke, so they've usually got lung disease. You know, they've got diabetes, they've got lots of things that we have to be aware of and we have to manage. So I think I'm really pleased that there's a dual qualification coming out, and I think it's really important that we support staff to undertake that, because that's about their confidence in thinking, I can think about this differently. But I think we need to recognise as well that it's not just necessarily the answer. I suppose coming to your point about am I engaged in the recruitment things, not from a district point of view, I'm involved in conversations within the trust about how we get staff in, or how we could fit a role into an establishment in a slightly different way. Because I think sometimes you've just got to think about it slightly differently. And I'm a big believer that sometimes we've just got to try something different, because if we're in a little bit of a stuck position, it's because what we're doing isn't necessarily working. So let's just think about it slightly differently.
Thank you.
Is that okay, Janice? Yeah.
I'm not going to interrupt Mel. I just had a comment, but I'm not interrupting.
Yeah, thanks. Yeah, Mel, I'll bring you in, please. Yeah.
It was just on that very point, actually. We had our exec to CBU conversation with our children's services earlier this week, actually. And, you know, clearly the lack of availability for very specialised, complex, particularly adolescents and young people with those sort of dual diagnoses, or even, you know, just eventually not necessarily a physical problem keeping them, but one of where is the best place of safety and where they can receive active treatment for their psychological or mental health challenges, is one that sits with us, because, you know, we often have these individuals within our clinical base for several weeks. And so we had that very conversation. The dual qualification is great. It's not here now, it's going to come. But there is nothing stopping us taking some of the resource that might have been deployed in a registered children's nurse and converting that to a registered mentally qualified nurse who has all the experience that can be deployed. You know, there's rarely a time where we don't have at least one of these children and adolescents in our paediatric services. So and all the kind of indirect benefits of having them there caring for that individual in upskilling the registered nursing workforce is entirely a sensible and appropriate thing to do. So we've laid that challenge to that team, and they're actively looking at that and are really interested in making that switch.
Thank you. Thanks. That's useful context, Mel. Thank you very much. Yeah. And Janet, did you say there was just another comment you wanted to? Yes.
It's reassuring that, you know, we are holistic. We're looking at comorbidities, not in the older age group, but yeah, a younger age group too. And some of the issues you identified, Sarah, the future nurse standard should address. So there may be much more depth in the expertise that you're all needing, we're all needing ahead.
Yeah.
That's great. Thanks very much, and thank you to you, Sarah. So, in concluding, Sarah, it was good actually how you finished, because you brought our attention back to the key points you were talking about for the next 6 months or so. What could we do as a board of directors? Is there anything you'd wish to finally, in conclusion, say to us in terms of how we might support you?
I think you have supported me, to be honest. I think we are in a different place to where we were 12 months ago, and I think that is, you know, because mental health, as we know, you know, it's every time you turn the radio on, every time you turn the TV on, and it's great for me personally that it's now got the, you know, the recognition and the voice that it needs, really. So I do think I think we're in a better position, and I am very thankful for all the support I've been given, because I know I'm very lucky that I've been given a lot of support around the mental health agenda. And I suppose it's just that continuation, really, that I suppose my plea would be for our staff, really, is that when I go out and about, I know that staff are tired. I know that they've lost a bit of the resilience, but they keep coming to work and they keep carrying on. And I think that's all credit to our staff. I think we've got a marvellous workforce who, despite the challenges and despite everything else that's going on, still turn up. But it is that bit, I think, if you're out and about, if you can just ask staff how they are. Yes. I think that'd be great, because I think it'd be really appreciated. I know when I go out and about, I always say, come on, how are things? And I get a wide ranging response, and that's fine. It is fine, and I'll say to them, it's okay if you're not all right, that's fine as well. We'll have a conversation, but I know that they appreciate it when we ask. So I think that would be my only plea, really, at the minute.
No, well said, Sarah. That comes from somebody with 25 years experience in mental health nursing. So we are listening, and we will apply that. So obviously, it's you go from here with the full support of the board of directors, very much appreciated. And actually, we'll finish on a nice point there, haven't we? About we know that this is an increasing issue for attention and vigilance on our part. And that final point you made about the value of asking people how they are is really helpful. So very well said. Thank you for bringing to our attention the strategy and what's coming up. And again, we can't always deal with everything at a board meeting. We're getting through a lot of business, but I know people will reflect and think and perhaps pass anything through that they may have thought about after reflection. So yeah, thank you very much indeed. Great stuff. Yeah. Karen, I should just perhaps pass to you as executive lead and make sure there was nothing further you would have wanted to bring to directors' attention.
No, just thanks to Sarah and her team. Ash coming along has made a huge difference to the work and the pace that we can do. So just thank you for their drive and resilience, because you know, Sarah and Ash put a lot of this into it themselves. So well done to them.
Yeah, great stuff. Thanks, Cam. Important stuff and a really useful and helpful briefing from Sarah, who's obviously spending a lot of time on this. So it's great stuff. Okay, one item then we'll do so we'll finish the first half, shall we, by dealing with our procurement strategy, which does deserve just a moment of pause and thinking and making sure we're happy. So I think we have Matthew supporting us with this. I can see that Michael and Shahid have authored the paper, or co-authored the paper. I'm not sure that they have necessarily joined us. And as I said at the start, I did just want to give a heads up to Altaf, because I know he has an expertise in procurement from exterior to here, and has been cited on some of the things to discuss. So shall we pass to Matthew then, please, to bring to our attention what the board needs to consider, but this is a matter for approval, and then we will then take a short break. So Matthew, can I turn to you, please?
Yeah, okay, thank you, Max. So yeah, as you say, it's a paper submitted for approval. It's been through a round of meetings internally already. It's been to ETM twice, F&P a couple of times, and at the request of the audit chair through audit committee as well. So, and it's also been reviewed at the first procurement oversight group that we have introduced, with very much thank you to Altaf for helping us with that group as well. But just I don't expect, I'm not going to go through it page by page, I'll take it as read, but just from a wider context, you know, the team are coming out of a very, very challenging 2 years, and it is only a small team, but you know, the paper is looking at what we need to do to maintain a resilient and safe and fit for purpose function going forward. It's a heavily regulated environment, and you know, it will continue to focus on compliance, control, assurance and transparency, and they're some of the key headlines on the front page. We do recognise though that the landscape is forever changing, and there's a real focus on what does it mean to work collaboratively across a regional footprint. That is not without its challenges, but it's something we are heavily engaged in. But we also know the national framework is also changing, and we do expect the procurement bill to be processed through Parliament. Not sure when, but it's in the process, and that will have a greater emphasis on social value. We've already been asked by NHSEI to consider how we build in social value from a local procurement and a sustainability perspective into our tendering processes, and so we have changed how we undertake some of our tenders. But you know, there's quite an emphasis on the forward look, but I do appreciate that it's at quite a high level, and some of the next steps I'll come on to about more focused, detailed work plan. But it's looking at how we can develop and evolve our systems, looking again at collaborative implementation across the ICS. How do we conduct our business? And that goes back to a bit to the social value. Are we getting the right balance between value for money efficiency, but also the local and resilient supply chain, and are the products actually out there from a local perspective? We do need to look at our logistics arrangements in terms of our just-in-time stock holding compared to a larger stock holding model, and that's something that we do need to test, because in this current environment, is that the right one for us to look at? And it does signpost other areas as well that we're looking at, from the governance of the team, the accreditation of the team, the training and awareness of the organisation. So it tries to capture it, and I do appreciate it in quite a high level. So the next steps that we're looking at are translating it into a 1, 2, 3 year work plan, which we've got much more measurables that we can monitor through the procurement oversight group feeding into finance and performance. We do need to consider where we set our level of ambition against some of these, and local procurement is a good example. Where do we set where do we want to be in 12 months time? And I know, Max, you've already asked this question, what does our baseline look like? And that's something we're going to have to work on. It's not an easy thing to extract, but we do need to establish a baseline so we can set that appropriate level of ambition. We do need to understand how we might resource this ambition over the next few years, and also how will we measure success, and what key KPIs will we look at. We benchmark reasonably well as a team. We're in the upper quartile for a few of the metrics in Model Hospital, or bang in the middle for others, but there still are areas for improvement. So there's a lot, quite a lot of information in there, a lot of it quite high level. It signposts where we need to be. The next step is translating that into meaningful actions and outcomes as a team that we can then start to take through the performance management arrangements, through the oversight group, and through the Finance and Performance Academy. So hopefully that just gives you a quick snapshot of the detail in the paper.
That's really helpful, Matthew. Thank you very much. And indeed, thank you for mentioning a point I was going to raise. I'll just share with directors that there was a desire amongst Yorkshire and Humber chairs to at least to be able to articulate the percentage of spend, procurement spend, that was local. And so, within either the Bradford Place, of course, or Yorkshire and Humber region. And so Matthew very helpfully came straight back to me on that, explained that it's quite a challenging area, but indeed has assured us that there's some work underway on that. And Matthew, just one thing I wanted to check, and I'll open for questions, was do we have some reasonable autonomy over our own procurement strategy, or are we directed by the ICS, for example? I genuinely don't know that. It's not a loaded question, but I know there's a partnership procurement strategy. So how much local autonomy do we have to influence what we do as BTHFT?
No, we have a lot of local autonomy. Clearly, we would want to complement the ICS strategy, but ultimately, a lot of it is up to us. We wouldn't want to go out with what the overall ICS framework might look like, but yeah, absolutely a lot of autonomy.
Thank you. That's really helpful. Okay, I'll open up for any questions or comments or thoughts. Of course, we've simply been asked to approve the draft procurement strategy, but I'd welcome any thoughts, comments, questions. Altaf, would you like to come in, please?
Sorry,
That's it. Can hear you now, Altaf. Yeah.
Getting off mute. Yeah, yeah. So I mean, this is detail, and it's things that we can work on as part of the procurement oversight committee. And I was just really looking this morning at the document that was referenced in our procurement strategy back from 2012 called Raising Our Game. And one of so I'm just going to pick it leaves like 12 asks of trusts as to things that we should be looking at, and then also gives 15 asks for the then Department of Health. So I don't propose to go through every single one. I'm just going to highlight a couple of it really for expediency and time. I mean, and we're not the only ones. Back in 2012, it sort of asks the suppliers to provide GS1 JITINs and associated data as an integral part of the procurement process. We have been asking suppliers to do that for, I'm assuming, for a length of time. And one of the things I'd like to see is some hard and fast timelines against that. So, some goals around at least 90% of our product catalogue to be covered by the associated JITINs. I mean, I know that sounds horrifically onerous, but it's very, very easy technically to get a JITIN if you're inclined to do so as a supplier. And we have sort of collaborative third-party suppliers who still use proprietary codes. So that, as we know, has an impact in terms of transparency, clinical efficiency, and patient risks down the line, and it has and it's quite rightly referenced as part of our scan for safety requirement. So that's one area. And the other area I think is more an area for us to develop as part of the procurement oversight group and the board to consider. Is it's very important for us to decide in the long term, what is our strategy? Are we gonna have storage and fulfillment capability within the trust? If so, then our current storage capability and handling capabilities are inadequate and not fit for purpose for us to do that. If we're going to, a lot of the private sector have looked at developing close collaborations with third parties, but they have very, very determined frameworks around that so that we ensure delivery of our needs are met in a timely and a critical fashion. So we need to decide whether that's a road we're going in that time. That then demands that we skill up for such an environment, or if we choose to bring a more of a stockholding position, then that's an area we've got to create greater space, infrastructure and investment for. So I mean, that's the only thoughts I'm going to park everybody on. I think it's not just a question of approving the procurement strategy. There's thought. The paper, the original paper asked for a continuous loop back to the board, and the board to be involved and cited on procurement as a key part of its function. And I think we need to be mindful of that, really.
Altaf, that's really helpful. Thank you. And thank you for your interest and expertise in this area. Altaf, can I just check? I think I am. Am I reading you right that you're not suggesting the procurement strategy is deficient in those areas, but that you would recommend that attention is paid to the issue of GSI timelines and long-term strategy, storage, etc.? Yeah.
That's correct, Max.
Yeah, they're areas for attention. And as you say, you're encouraging that circle back to the board all the time.
Sure.
So yeah, that's helpful insight. Thank you. I will, of course, ask whether Matthew has any response to that, but I'll just check whether there's any other points that have been raised. But it's great to have that non-executive assessment and input and expertise there. Thank you. Julie, would you like to speak, please?
Just quickly to say, important to say, this document came to F&P and we approved the strategy on the basis that we would want to see some of the answers to some of the questions that were posed in the strategy coming back to us. So, you know, value the work of the procurement oversight group, but some of the issues Altaf raised, it'll be really good for us to see back, where do we land then? And do we have some input into that as a board if necessary, around some of the local procurement stuff? What's the right answer? So we approved it on the basis it was a document that raised questions and didn't answer them all. But I think, as Altaf said, we need to see back through that loop and actually see where some of these decisions land. But really important job for that procurement oversight group to do on our behalf.
Yeah, yeah. But well said, Julie. Thank you. And as chair, can I endorse that point about this directed visibility of where we're going with procurement is very welcome. And very in keeping with the Anchor Institution ideas, of course, that John raised earlier. So good stuff, Julie. Thank you. Yeah, Board and Academy insight into procurement. Thank you. And particularly noted the two key points that Altaf brought to our attention. Anybody else have anything they would wish to say? No? Shall I go back to Matthew and see whether there's any response to the points raised, Matthew?
Yeah, so thank you. So in relation to the two that Altaf raised, the one around our storage facilities, absolutely front and centre in the strategy already. It talks about our just-in-time and inventory management model, and whatever came, it would absolutely need board approval because it would require significant investment if we were going to change the model that we currently have. There are advantages and disadvantages to both models, but we need to know what the future environment of the overall national supply chain looks like as well. That might then maybe a driver on what that looks like. The one around the JITINs, you know, we do, when you look at model hospital, we don't do too bad from that metric, but I think we can absolutely do better. And you know, it's one of the metrics I think we just need to focus on when we're looking at our overall scorecard for procurement, when we're reporting back to the academy or through to the oversight group as well. And absolutely take Julie's points on board, that we recognise that this was a reasonably high level plan that signposted the opportunities that were available to us and where our direction of travel might be. What it didn't do is say, right, in relation to area A, what are the 4 or 5 key objectives or outcomes that we are exploring, and how will we measure that outcome, and how will we report back? That's going to form part of the work plan that we will be developing now over the forthcoming period. And can I just round up by saying I'd just like to put on record my thanks to the procurement team, because they have worked tirelessly throughout the pandemic, and they're a very small team. So it's just just to express my thanks, really, put it on record. Thank you.
Well said. Well said, Matthew. And obviously the group that's been formed is going to be extremely important in terms of the work that it's undertaking. Great stuff. And Matthew, could I just bring to your attention, I'm sure you'll be aware of this already, but of course, what we do here may fit very nicely with the Bradford District Economic Strategy, from which many directors got a briefing. Does that sound familiar?
Yeah, so interestingly, Mel, a couple of months ago, had a discussion, I think, with the local authority, and an opportunity to develop a relationship with the local authority procurement team. So I think Michael has been in touch, or tried to get in touch with the local authority. I don't think anything's come of it as yet, but we've made that initial contact.
Brilliant, that's great. Well, we had a terrific, and of course, exec directors joined non-execs to meet Professor Zahir Irani, the author of that strategy, and he was delighted with our interest and support. So it'd be great if we keep that in mind. That's acting as one, isn't it? That's acting together. So great stuff. Yeah. Thanks very much, Matthew. Thanks, directors. The comments you made there were really, really helpful, and I was pleased to hear of those. Altaf for the particular issue, the potential gaps you raised, and Julie's great points about keeping director visibility by the right routes. Directors, are we content to approve this procurement strategy that's presented, please, in light of the comments made as well? Yeah, it would appear there is unanimous support for that, and I'm grateful to everybody for reading it, for thinking about it, and for the comments made, and that is approved. So that's great. Matthew, thank you for bringing that, and yeah, endorse your thanks to the teams that are working on this. Hugely important as we move forward. Great stuff. Okay, what have I got? 12:08. Shall we pause now to 12:20? Yeah, and then we'll have a 2-hour second half in which we'll try and get the academy business dealt with. Yeah, so yeah, let's pause now, and we'll reconvene at 12:20. And what we'll do is we'll start on the quality matters, given that we've got 2 guests who are waiting to join us for those. Yeah, so okay, let's take a pause, and I'll see you at 12:20. A good 10 minutes. Thank you, everybody. Really good morning's work. Great stuff.